The subcommittee hearing is called to order. Good morning and welcome to our witnesses on the first panel. This is the second in our series of hearings on health reform. Today, the subcommittee will examine issues surrounding the affordability of health coverage. Now more than ever, securing quality health care coverage at an affordable price is not possible for millions of American families. First and foremost, health insurance has become too expensive. As health insurance premiums continue to outpace wages every year, people can no longer expect to pay a reasonable price for health coverage. And as we talk about health care reform, we have to ask ourselves, what should we expect to pay for health care coverage, and what should that coverage include? Cheap plans that offer little protection, such as high deductible plans, are not a solution, in my opinion. We need real reform that makes quality health care coverage affordable to every American. And in order to do that, we need to change the rules which govern the way people obtain health care coverage, particularly within the individual market. I'm particularly interested to hear from our witnesses today about new ideas like a health exchange or connector, similar to the one in Massachusetts, a public plan option, and an individual mandate that can help provide individuals access to affordable options for meaningful coverage. I also think it's important that as we talk about making coverage on the individual market more affordable, we don't do anything to disrupt the affordability of coverage in other sectors. There was talk last week and in the media about eliminating or cutting back on the tax exclusion for health benefits offered by employers. This was an idea promoted by former President George Bush and was a key component of Senator McCain's health care proposal during his presidential campaign. But obviously this is controversial as well. The employer market is already declining. It's becoming increasingly difficult for both employers and employees to afford health care coverage, and eliminating those tax incentives may further exacerbate the affordability problems we already face with employer-sponsored insurance and make it and not necessarily do anything to improve the affordability of coverage in the individual market. Again, these are all issues that I think we need to discuss, looking at places like Massachusetts, public plan options, individual mandates, and the tax exclusion for health benefits. Not that I'm taking a position on any of those right now, but I think these are important things that we have to look at. I want to thank our witnesses again for being here today. I know we have a very distinguished panel, and I'll now call on Mr. Deal for opening statements, and then we'll have opening statements from our other members, both Democrat and Republican. Thank you.
Thank you, Mr. Chairman. Thank you for holding the hearing today, and thanks to the witnesses for being here, and I believe we have two panels of them, so we're going to be here a while, I suppose. Obviously, as we broach this subject of how to reform the health delivery system in this country, it is a difficult task and one that has many facets to it. Dr. Reinhardt, I was interested in reading your article that appeared back in January on in the New York Times on the question of pricing. As you probably know, this is an issue that has been one that's been important to me in the area of transparency of pricing. It's probably one of the most difficult issues to understand and try to get a handle on. We have so much differences in pricing of health care services in this country that it is, in fact, I think one of those issues we have to begin to wrestle with if we're going to decide how we're going to approach the delivery of health care, because pricing obviously has a lot to do with it. I'll look forward to the testimony of the witnesses. There are a lot of issues that we have not talked about in previous hearings, and I'm sure that these two panels today will broach some of those subjects that we have yet to explore. And thank you for being here, and I look forward to your testimony. I yield back.
Thank you, Mr. Deal. The gentlewoman from California, Ms. Eshoo.
Thank you, Mr. Chairman, for holding not only today's hearing, but the series that you've planned as we work to bring health care to every American. One of the biggest problems in health coverage is including those who are left out of group coverage and must purchase insurance in the private market. These very same people not only face tougher access and higher cost issues, but they're also taxed on these plans. Any individual who receives coverage through their employer gets their plan tax-free. I think it's very important that everyone has the option to buy into a group plan that would mitigate costs and not discriminate based on pre-existing conditions. We don't want to upset the health insurance for people who have it and who like it. We want to expand affordable, comprehensive health care options to those who don't or those who want better coverage. So I look forward to a very distinguished panel's testimony today, and I hope we're able to discuss the tax treatment of health insurance and how we might address that as well. Thank you.
The ranking member of the full committee, Mr. Barton.
Thank you, Mr. Chairman. I've got an excellent statement that my staff's prepared. I'm going to submit for the record. But in the interest of time, I'm going to just submit it. The main thing that's in the statement that I think we need to put before yourself and the members of the committee is that the Republicans do want to work in a bipartisan fashion this year. We are willing to work with you and the full committee chairman and other members on the majority side to enact comprehensive health care reform if it really is reform. So this is not an issue where we're going to try to rope-a-dope the committee. We're prepared to work if it's something that is in the middle and can be done and maintain the private health care plans of America.
Thank you, Mr. Barton. I appreciate what you said, and I think it's crucial that we work in a bipartisan fashion, and that is certainly our intention. Thank you. The gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. I want to thank you for holding this second hearing on health care reform. Our state of Texas has the unfortunate distinction of having the largest number of uninsured in the United States. Nearly 5.4 million Texans, or 25% of the population in Texas, without health insurance coverage, and nearly 1.4 million children are uninsured. Of that 1.4 million, 900,000 children in Texas are S-CHIP eligible. We need a national system designed so that every American should be covered, either an employer-based plan, an individual plan, or a public plan, no matter what state they live. The largest rate of growth in the uninsured and underinsured are middle-class families who make too much to qualify for public plans, but don't make enough money to pay costly premiums under the private plans, and those who work in low-wage jobs without employer-based insurance. Ultimately, the large number of uninsured Americans create a vicious cycle by driving up health care costs, which increases the number of people who can't afford insurance. Mr. Chairman, I ask unanimous consent to have the remainder of my statement be placed in the record.
Without objection, so ordered, and thank you. The gentleman from Kentucky, Mr. Whitfield.
Thank you, Chairman Pallone, and I'm going to waive an opening statement.
Next is the gentlewoman from Colorado, our full committee vice chair, Ms. DeGette. Mr. Shimkus?
Thank you, Mr. Chairman. I, too, am excited about getting into this debate. Basically, how do we make sure we get insurance for those who don't have no insurance? So my focus has always been affordable, portable, and access. I do believe that the market-based system, which encourages price transparency and shopping around, is the best method. I do fear a government backstop plan action in which the government controls. And I'm deadly in opposition to a one-payer system, which I hope we don't segue into when this fight really gets going. I do not want bureaucrats picking health care decisions in the end. So having said that, it's great to be back on this committee. As I said, Mr. Chairman, I look forward to working with you. I yield back.
Thank you. Our subcommittee vice chair, Ms. Capps.
Thank you, Chairman Pallone. Since today's hearing is about ensuring affordable coverage, I want to quickly set the stage with a story about my constituent, Terry Turpin. Her story was featured in the Ventura County Star yesterday, and I'd like unanimous consent to enter the article for the record. She, like so many others, recently lost her job when her employer filed for bankruptcy. Unfortunately, Terry had just been diagnosed with a relapse of cancer only a month earlier. COBRA would have cost her well over $500 a month. So she applied for coverage in the individual market, but never heard back because of her pre-existing condition. Luckily, Ventura County has a wonderful public health system where she was able to get access to oncology treatment. Not everybody lives in a community that provides that backup. At the bottom line is that patients shouldn't have to switch providers in the middle of treatment because they lose their job. So I look forward to discussing today how we can improve access to affordable coverage for everyone. I yield back.
Gentleman from Missouri, Mr. Blunt.
Thank you, Mr. Chairman. I have a statement for the record. I do look forward to working with you and with Mr. Deal and the subcommittee to find a solution to this question of affordability. I think we can find common sense solutions. In fact, the Medicare Part D program that's been in place now for several years is an example of a program where for the first time the government organized a private, competitive-driven system rather than try to operate a system. The cost is lower, satisfaction is higher, seniors have more options. In fact, competition works, and it puts patients and healthcare providers in control. There is no government-run plan offered under Medicare Part D, and in fact, there's no government-run plan offered for members of Congress or any other federal employee, and I think there's a good reason for that. People want choices, and choices bring greater satisfaction. I look forward to the testimony today, Mr. Chairman.
Thank you. Chairman Emeritus, Mr. Dingell.
Thank you for your courtesy, and I commend you for this hearing. First of all, this is an important hearing on affordable coverage. Addressing affordability is a crucial piece of health care reform debate. This hearing will help guide us in our future deliberations. The amount that workers pay for health insurance has greatly outpaced the rate of inflation and certainly has risen faster than stagnant wages and incomes. The statistics are frightening. The share of family income spent on health insurance increased from 7.3% in 1987 to 16.8% in 2006. In 2006, 1/5 of the nation spent more than 10% of their income on out-of-pocket medical expenses. In 2007, 69% of the people who went without medical care or delayed needed medical care cited worries about cost, a 3.8 percentage increase from 2003. The average cost of employer-based family insurance policy in 2008 was $12,680, an amount almost equal to the annual earnings of a full-time minimum wage job. It is not just the uninsured population that suffers from the high cost of health care. More than 42 million people with health insurance report having problems paying medical bills. Of those who faced medical bankruptcies, almost 3/4 had health insurance at the time of the illness that left them financially unstable. Without any action, the expected cost of full family employer health insurance will increase to more than $24,000 in 2016, and the average deductible will reach nearly $2,700. This means that in only 7 years, almost half of American households will spend more than 1/3 of their income on health insurance. It comes no surprise to anyone that families are literally going bankrupt. The high cost of health care causes a bankruptcy every 30 seconds. At the end of the year, it'll cost $1.5 million the homes which they cherish. Furthermore, as health care costs dominate budgets, families will have less to spend on food, education, and necessities. As we continue the debate, we must ensure that every American has coverage, but we can't stop there. Increasing costs alone will get us nowhere if we don't find ways to reduce the cost of health insurance and health care delivery as a whole. Access to health insurance does not mean that individuals can utilize available services. They're also kept out of the circle of care due to high premiums, deductibles, and other out-of-pocket costs. I look forward to working with my colleagues and working with the leadership here and the administration. There are a number of worthy options being debated. I think public option is something that should be seriously considered as we move forward on health reform. While we've not decided the specifics of what a public option should look like, I believe that such option must be affordable, and it must have suitable benefits, and it must provide healthy competition in the marketplace. The insurance market has a nasty habit of gaming the system. of building barriers to affordable coverage, of excluding coverage altogether, or coverage for pre-existing conditions, and charging higher premiums for certain individuals, cherry-picking, and other games that make insurance unavailable to our people. I am confident if we weigh our options with an eye towards the end goal of providing quality coverage for Americans, we can pass a reform that benefits all of our Americans. We must do so because the consequences of not doing so are terrifying. Thank you, Mr. Chairman.
Thank you, Chairman Dingell. Next is the gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman, for convening this hearing. Recently, the Pennsylvania Insurance Department released a survey of Pennsylvania health insurance. Let me just share a couple of results. Overall, in 2008, 15.3% of Pennsylvanians did not get some type of needed medical care during the past 12 months due to its cost. This represents about 1.9 million residents. Currently, 8.2% of Pennsylvania residents are uninsured. That's about a little over 1 million residents. According to the survey, the cost of health insurance remains the primary barrier to coverage. I believe any health reform plan must contain several key principles to empower the consumer. Among them, end tax policies that discriminate against an individual who purchases private health insurance on their own rather than through their employers, make it easier to decouple health insurance from employers. Those who own their coverage should be able to take their plan with them when they change jobs or quit working, and one they can take to another state. They should be able to buy from another state. Also, risk pooling within a state or across state lines. People should be able to choose the plan and doctors and services they want. And insurance and providers are accountable to them, not their employer or government bureaucrats. The bottom line is privately owned health insurance will lead to competition among plans, lower cost, higher quality, more choices, and more transparency. I thank all the witnesses for testifying. I look forward to hearing their thoughts and yield back my time.
Thank you. The gentlewoman from Chicago, Ms. Schakowsky.
Thank you, Mr. Chairman. I'll put my entire statement in the record, but I wanted to make a couple points. One, this debate about cost should not be about providing access to health insurance. It must be about providing access to health care. Too many insured Americans find that having an insurance policy is no guarantee that they or a loved one will be able to afford care when they need it. And finally, I want to point to a new report by the Illinois Main Street Alliance, in which 56% of small business owners in the state support a choice between a public insurance option and a private option. Those are the small businesses in our state. And finally, Mr. Chairman, I'd like to submit for the record a report from the Institute for America's Future, Massachusetts Health Reform, Near Universal Coverage, but no cost controls or guarantee of quality, affordable health care for all. If I may submit it for the record.
Without objection, so ordered.
Thank you, Mr. Chairman.
Next is gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. I was astonished a couple of weeks ago to be invited to the White House to the forum. I still haven't figured that out. But I was grateful to be there, and I heard the President observe that he just wants to figure out what works. And I'm certainly prepared to help him. Now, I always get a little bit discouraged on these panels and discussions. We end up talking a lot about cost and coverage. After all, as a physician, I can tell you it is about taking care of people in the final analysis. One of the things the President also told us was that the status quo is not an option. I would also observe that very little is static in the field of medicine, and in fact, in the 15 years since the last major attempt at reform was undertaken, medicine has changed drastically. Now, the President wants to figure out what works. We're going to hear a lot about former Governor Romney's proposal in Massachusetts that has now had a couple of years to go through a couple of iterations. It's a bold experiment. It deals with a connector. It deals with mandates. But maybe we should also look at Walmart, which in the past 4 years now covers, without mandates, 95% of its employees with affordable coverage. If we want to learn from what works, maybe we ought to include that in our broad-based discussion. You know, you look at the cost for the cost increases. It was referenced by former Chairman Dingell, the cost for indemnity insurance, PPO. In fact, Medicare and Medicaid all are going up in excess of 7% a year. Look at consumer-directed health plans, though, and they're rising at a rate of a little over 2% a year. It seems to me it would make sense that if we are going to deal with issues of cost and coverage, we would give a close look to those things that are working, particularly how Walmart has provided affordable coverage to its employees and how consumer-directed health plans have held the line on cost increases. I'll yield back the balance of my time.
Thank you. Gentlewoman from California, Ms. Harmon.
Thank you, Mr. Chairman. Healthcare reform can't wait. It is an integral part of any economic recovery strategy, and I think it is very good news that both the Obama administration, this Congress, and this committee know that. Let me just make 3 brief points. First, I'm new to this subcommittee, but not new to this issue, and I welcome the opportunity to be a player at some level as we craft legislation. Second, I urge that all of the expertise on this committee, starting with our chairman emeritus, but including every other member of the committee, Democrat and Republican, be tapped as we draft a bill. Third, of special interest to me is the lack of surge capacity in our healthcare system. Should we have another major terrorist attack or near simultaneous attacks, I would bet that all of our trauma centers will be full to capacity even before the latest victims get there. And finally, let me say that both wellness and preventive care are the cheapest options for health care, and I hope we feature both as we craft a bill. Thank you very much.
Thank you. The gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. Thank you for the hearing, and welcome to our guests today. You know, there's a saying, nothing in life is free, and in Tennessee, we have figured this out with our TennCare system. It's become proof of that. We've learned that comprehensive health care packages for all cannot be affordable. Government's resources to provide care are fixed, and as we learned, intervention can exacerbate rather than control the growing cost of health care, and Tennessee has been TennCare has been very problematic for our state. TennCare kept a blind eye to rising costs and overgenerosity. It imposed no limits on days in the hospital or number of prescriptions that were allowed each month, and in the mid-90s, each TennCare enrollee received an average of 30 prescripts per year. However, health outcomes in the state did not improve. So to control cost and expand care, we must look to market forces, not look past them. And while the private sector is in need of reform, it is more effective than the proposed government-run options being floated to bring about more efficient, higher quality, and more effective health care. This hearing is entitled Ensuring Affordable Coverage. I believe it should be entitled Ensuring Access to affordable health care options, and I say that because of the experience we have had in our state. The nation will achieve high-quality care at a lower cost when Americans are empowered to make choices and become prudent health care consumers. Thank you, Mr. Chairman, and I yield back my time.
Thank you. The gentleman from Texas, Mr. Gonzalez. Mr. Gingrey.
Mr. Chairman, thank you. Ensuring affordable quality health care for all Americans is a worthy goal, indeed a necessary goal. We should work to ensure that low-income families, those with disabilities or chronic diseases, and all who purchase health care on their own have the same opportunity to access health care as their neighbors. But access to an insurance card, no matter if that card is for a family health plan or a government program, it does not guarantee access to quality health care. In my state of Georgia, the number of general physicians has declined over 15% in the past 10 years. Unfortunately, Georgia is not an isolated case. Mr. Chairman, access to quality health care should mean that all Americans are able to see a qualified medical professional and receive a life-saving treatment or drug when they need it. Going forward, Mr. Chairman, it's my hope that this subcommittee will not lose sight of the fact that we will destroy, not improve, but destroy health care if we take actions to reform the system that drive doctors out of the practice. Thank you, Mr. Chairman. I yield back.
Thank you. The gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman. I waived my opening statement.
Gentlewoman from Florida, Ms. Castor.
Thank you, Chairman Plone. Our neighbors and folks all across this country are depending on us to tackle this health care reform effort and help make health care more affordable for their families. So we need your expert testimony now more than ever. The stakes are very high in my home state of Florida that has the second highest rate of uninsured. In fact, I was going through the comment cards in my office last night, and health care is the #1 issue. They know that it's not just their well-being, it's their economic well-being in a very difficult time. One constituent shared a story. I guess they felt so compelled, they were so offended by the fact they were waiting in line at the pharmacy behind a woman who was picking up insulin for a relative. And the pharmacist had to say, I'm sorry, your private HMO has declined coverage. We cannot provide the insulin. And they said, there's no other option? No, there's no other option for this expensive insulin. We cannot provide it to you. So that person, that neighbor waiting behind, felt so compelled to write to their member of Congress to say, this just is not acceptable in our country. The proof of dysfunction is legion. Now what we need are the solutions. So I look forward to your testimony very much, and I know that this committee will act expeditiously this year on health care reform. Thank you.
Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, for holding this important hearing. I'm particularly interested in today's topic of making health care affordable for working families. Unfortunately, our current system is far from affordable, and every day we wait, there are consequences. Ask Tammy Witt from Ohio. She was diagnosed with stage 3 breast cancer in April of 2006 and had to undergo a mastectomy and 9 months of radiation. Tammy was receiving what she thought was comprehensive health insurance from her job, but Tammy's low annual insurance benefit caps left her with unaffordable medical debt that eventually caused her to declare bankruptcy. Like Tammy, far too many Americans have to worry about facing bankruptcy when they become ill because of the cost of health care. We can do better, Mr. Chairman, by Tammy and families across this country. We have to do what we can to rein in costs and make health care more accessible and affordable, and I look forward to hearing from our panelists today.
Gentleman from Iowa, Mr. Braley. Ms. Baldwin.
Thank you, Mr. Chairman. I hear from my constituents every single day about the high cost of health care, whether they are insured or not. Brenda, a constituent of mine, was self-employed as a children's book author. Her small income disqualified her from being eligible for Wisconsin's public health insurance program, and she couldn't afford to purchase health care in the individual market. Last year, Brenda got a small kidney stone, but because she was uninsured and could not afford health care, she delayed getting it treated, to the point where she had to be hospitalized with severe infections and internal bleeding. She's no longer able to work and receives insurance from the public health insurance program now. We absolutely must tackle this issue if our reform is to succeed at all, and we must ensure that individuals like Brenda are able to access the care they need when they need it. In my last couple of seconds, Mr. Chairman, I just wanted to respond to some of the comments we've heard about having public sector options along with private sector options. Medicare Part D is used as an example frequently. I would note that in the state of Wisconsin, I think we're the only state that has a public sector option in the Medicare Part D program. It is very, very successful, and I hope that we'll be able to study it further as we have this debate about whether there should be both public and private sector options available to our constituents.
Thank you. Gentleman from Connecticut, Mr. Murphy.
Thank you, Mr. Chairman. I hope that we spend some time this morning talking about the fact that just because you have health care insurance doesn't necessarily mean you have health care. This is an important distinction that needs to be at the center of this debate. For instance, in Connecticut, we have a very generous Medicaid program, but because it doesn't pay doctors enough to be part of it, we have Medicaid recipients that can't find a psychiatrist or can't find an orthopedic surgeon no matter where they go. Before I came here, we had to pass a law in Connecticut that cracked down on private insurers that were charging $200 copays for MRIs, basically putting the entire burden of that procedure on the consumer. Universal health care insurance and universal health care are potentially very different things, and I hope that this hearing will push Congress towards passing a health care reform bill that guarantees that every American gets quality health care that they can afford, not just a claim of coverage or phantom access. I thank the panel for being here, and I look forward to hearing from you today.
Thank you. Gentleman from Utah, Mr. Matheson.
Thank you, Mr. Chairman. Cost is the issue. And today we're talking about affordability for families. We should be talking about affordabilities for everyone in America, families, businesses, the effect on small business. There's a lot of talk about access and making sure everyone has access to health care. If we give access to everyone under our current system and don't take steps to create reform in our system to make it more efficient, we're going to drive off the financial cliff even more quickly than we're headed right now. So I encourage this committee to continue to look at ways to make this system better. The good news is there's tremendous opportunity to make it better without spending more money. The current system is inefficient, it's not productive, it's got perverse incentives built throughout its structure. It's got a bloated administrative component that I can't believe we put up with as a country. So I think there are great opportunities for this committee to act in the best traditions of the Energy and Commerce Committee in a bipartisan way, to be substantive, to look at multiple variables that really need to be addressed if we want to reform our healthcare system. That's what this committee ought to do, and I look forward to this hearing and additional hearings in the future. Thanks, Mr. Chairman.
Thank you. And that, I want to thank all of our members for their opening statements, and now we'll turn to our witnesses, and welcome to all of you. We have a very distinguished panel with us today, and I'm going to introduce them from left to right, and then we'll have 5-minute statements from each of you. First, again, to my left is Dr. Uwe Reinhardt, who's professor of political economy, economics, and public affairs at Princeton University in my home state. Thank you for being here today. We have Ms. Sally Pipes, who is president and chief executive officer of the Pacific Research Institute. And then we have Dr. Judy Fader, who is senior fellow of the Center for American Progress Action Fund. She also has been before our committee many times in the past, our subcommittee. So thank you all. And if we could start with Dr. Reinhardt. Is your mic on? I'm not sure. You pressed the button?
Yes, it's high tech.
That's good.
I'm from rural New Jersey, as you know, and I have to learn these things. I have submitted a statement to the committee. It falls into 3 parts. In the first one, I briefly visit the issue of costs, just to remind Americans how expensive our system is. The second one, I look at what this cost does to American families, looking sort of at the median American family. And then in the final, have some perspectives on proposals before the nation to fix this problem. Now, it is well known that we spend on a per capita basis in purchasing power parity a lot more than other nations, 56% more than Switzerland, which is viewed as a very high-quality healthcare system, and 83% more than Canadians do. And yet, if you look at health statistics, you will not find that much difference. In fact, I find it an intellectual breakthrough of major proportions that the Business Roundtable, which used to be the staunch defender of our system as the best in the world, now comes out with a report just last week talking about a 20% value gap, saying relative to other nations, Americans get 20% less value for the healthcare dollar than other nations. That's a very important recognition by these important people. I also remind people of what we call the Wenberg variations. For example, that under Medicare, it costs more than twice as much per elderly in Miami than it does in San Francisco, which is an issue I believe the Congress should begin to look into fund research to say, why should it cost twice as much in one part of the country than in others? But it's not just the Medicare. You will find the same in private insurance as well. So I believe cost-effectiveness analysis, which is a dirty word yet on the Hill, at some point does have to be embraced. It's just called operations research. There's no other industry that wouldn't look at cost per unit of output. Healthcare is really the only one. But I also would urge Congress not to say, let's do cost control first and then universal coverage, because we've said this for 30 years. We've never done the former, and I don't think you can fool God that long with the excuse that we cannot afford it. We've said this now for 30 years. It's time to go to universal coverage. In the second section, I look at the American family. I use for this not health insurance premiums, which is a very misleading indicator. I use the Milliman Medical Index, which includes the premium for health insurance for the family, plus their out-of-pocket spending. Because you can always make premiums go down or slower just by cutting the benefit package, raising deductibles, and so on. So you really should look at the Milliman Medical Index. Last year, on average, for a family of four, it cost $15,600 for health care in America. It'd be now $16,500. Now, compare that to the median household income in America in 2007 was $51,000. So if one had the view that people should be responsible for their own health care, you would be saying for a median American family that they should spend $16,000 out of their $51,000. That's an awful heavy burden. Now, for lower income families, as your statement correctly says, 30% of available discretionary income goes for health care. So what I predict that in the next decade, I have a little table here. I use a family here with a wage base of $50,000 and say if that wage base grows at 3% and healthcare spending per capita by 8%, which is what it has been for the next decade, then half that family's wage base would be chewed up by healthcare 10 years from now, half. Even if you make very optimistic assumption that health spending grows only 4% and wages 5%, it's even unthinkable given what we're facing right now. But even if you make that, 30% of that family's wage base would be chewed up. So we're sailing into a perfect storm, and the Congress at some point faces the following question. Either taxes have to be raised on those of us fortunate to be in the upper part of the income distribution, myself included, or, and then you could have a roughly egalitarian health system, or you seriously have to redesign the system to ration healthcare by income class, which is, of course, what we have been doing already. And this is a sort of mischievous piece of mythology that government-run systems like Canada's ration healthcare and private markets don't. If you have a specialty drug that costs $100,000 a year, and you ask somebody to pay a 30% coinsurance for getting that drug, you are rationing that person out of that specialty drug if their income is $50,000. I mean, it's just, every textbook in economics will tell you that prices ration is just one other form of rationing. So this is what the Congress faces. And then look in the last section at the individual market and presents several models. I don't have time to go into it, but there is the issue of the public health plan. Given what the American people have witnessed, they have seen great American companies, AIG, GM, Citigroup, go under. Given what the shock they have received, one could imagine that Americans would yearn for an option that is government, because I believe in the end it's the government Americans trust, because that's where they always run to when they get in trouble, whether they're big bankers or whether it's FEMA or whoever it is. When the going gets tough, the tough run to the government. That is the slogan, and I've observed it for 40 years in this country. So therefore, I believe that people say we shouldn't have a public option, have a tall order to explain to the American people why they should be deprived of a choice that they may yearn to have. And I then go through later on how one could make that a level playing field. It is, after all, only a choice. You don't have to choose it. You can go private, but it should be, in my view, I as a citizen would love to have that option, and I might even take it. Thank you very much.
Thank you, Dr. Reinhardt. I want to make sure I got this quote. When the going gets tough, the tough run to the government?
Yes, that is
Okay.
the marching order of the rugged individualist.
Thank you. Ms. Pipes.
And that's probably me. Thank you very much for the opportunity to testify. I think we would all agree that all Americans want affordable, accessible, quality health care. The question is, how do we achieve that goal? And there are two competing visions for reforming health care and achieving universal coverage in this country. One focuses on patient-centered solutions, empowering doctors and patients, and encouraging innovation in new pharmaceuticals and medical devices. The other vision is focusing on increasing the role of government in our health care through higher taxes, mandates, and subsidies. This vision for greater government involvement is on the rise today, and I think we need to focus on the fact 47% of health care in this country today is in the hands of government through Medicare, Medicaid, S-CHIP, and the VA system. The long-term goal of the new administration and many Democrats in Congress is Medicaid for all. And as has been pointed out, the U.S. today spends 16% of GDP on health care, about $2.3 trillion, and many people say that that is too much. And if we're going to get that percentage down and achieve universal coverage, how do we reduce the number of uninsured from the 46 million Americans? Canada, my country of birth and where I spent most of my career working as an economist, spends 10% of GDP on health care and does have universal coverage. If Canada has universal coverage and only spends 10% of GDP, why can we not duplicate that model? The Canadian government took over the Canadian healthcare system in 1974 and banned any private health care for procedures provided under the Canada Health Act. Of course, the demand for health care was much greater than could be provided by government. As a result, Canadians suffer from long waiting lists for care, ration care, and a lack of access to the latest technological equipment. A few statistics. 750,000 Canadians are on a waiting list waiting for procedures. 3.2 million Canadians, out of a population of 32 million, are waiting to get a primary care doctor. The average wait today from seeing a primary care doctor to getting treatment by a specialist is 17.3 weeks. That's over 4 months. Canada ranks 14th out of 25 countries within the OECD on MRI machines and 19th out of 26 countries in CT scanners. When the government is the monopoly provider of health care, people wait and wait. When they get tired of waiting or are too sick to wait further, they flee, if they can, and many come to the United States for treatment. Belinda Stronach, former Member of Parliament in Canada, opposed opening up the Canadian healthcare system to any private side, but when she was diagnosed with breast cancer in June 2007, she came to UCLA and had her breast cancer surgery done and paid for it out of pocket. A woman in Calgary, Alberta, expecting quadruplets last year, there was not a single neonatal unit in Calgary, in Alberta, or in Canada where she could deliver her quads. She was airlifted to Great Falls, Montana, a city of 55,000, and her quads were successfully delivered. I have many, many stories of people in my family. My mother couldn't get a colonoscopy at her age and died within 2 weeks when she was hemorrhaging in the emergency room. Dr. Brian Day, orthopedic surgeon and former president of the Canadian Medical Association, told the New York Times, Canada is a country where a dog can get a hip replacement within 2 weeks. A Canadian citizen has to wait 2 to 3 years. In June 2005, the Canadian Supreme Court ruled on a case for the province of Quebec that the ban on private health care and private insurance is illegal because of the long wait times. Madam Chief Justice Beverly McLaughlin said, access to a waiting list is not access to health care. Canada is opening up its system, while the U.S., it seems to me, is moving more towards a government-administered system. President Obama has said that employers would have to provide coverage or pay a payroll tax so that employees can get coverage within a new government-run insurance plan, which would be part of a newly created national insurance exchange. The exchange would also include private insurers. I think the government insurance and the private plans would have to have guaranteed issue, community rating, and many mandates, which will make them even more expensive. My view is that the government plan will be priced lower than the private plans. I see ultimately crowding out of private plans and taking America down a fateful road to Medicaid for all. We would then have universal coverage. We would not have universal access. Care will be rationed, taxes will increase significantly, and the entrepreneurial spirit of this country will be weakened. When we get totally socialized health care in America, where are we going to go? We can change the tax code, as has been mentioned, by removing the tax advantage to those who get their insurance through their employer. We could offer, as McCain suggested, a refundable tax credit for everyone. We want to empower patients. We want to reduce state mandates, which add between 20 and 50% to the cost of an insurance plan. I think people should be able to purchase insurance across state lines. We need med-mal reform, and if we do all that, we can reduce costs and significantly reform and reduce the number of uninsured in this country. Universal choice will lead to universal coverage for all Americans, and then we will have affordable, accessible, quality health care for all. As P.J. O'Rourke, my friend, says, if you think health care is expensive now, just wait until it's free. Thank you.
Thank you. Dr. Fader.
Thank you, Chairman Pallone and Congressman Deal and members of the committee. It's a pleasure to be with you today to talk about the critical need for affordable health care for all Americans. As I listen to Ms. Pipes, I wonder whether she is truly following the plight of Americans who can't afford health care, and whether she's following the kind of American health reform that we're really talking about. You mentioned President Obama's campaign plan. He has talked about his commitment of the choice of health plan, of quality care, and affordability for all Americans. So I'd like to get our attention back to the problems Americans are facing, as 14,000 Americans are estimated every day to be losing their health insurance as they lose their jobs, and as benefits are shrinking even for those Americans who have health insurance. The problem of unaffordability is most apparent for the now probably more than 47 million Americans who lack health insurance, most of whom have incomes below twice the federal poverty level, about $44,000 for a family of four. And if they don't get health insurance through their employers, as most of them don't, though most of them are working, they simply can't afford the $13,000, roughly 2008 cost of a comprehensive health insurance policy. But affordability, as you have noted, is increasingly a problem even for people who have health insurance. In 2007, for example, the Commonwealth Fund identified 25 million people underinsured or economically threatened due to high out-of-pocket costs, up from 15 million, so that's 15 up to 25 million in only 4 years. Similarly, the number of Americans who report problems paying medical bills has risen. It's jumped from 1 in 7 Americans under age 65 in 2003 to 1 in 5 Americans by 2007. Not surprisingly, low-income families face the greatest problems, and sadly, our valuable Medicaid and CHIP programs do not necessarily prevent these problems. No matter how low their incomes, working-aged adults who are not parents of dependent children or are not disabled aren't eligible for Medicaid in most states. And even the populations for populations they do cover, Medicaid and CHIP have been modified in recent years to give less protection in terms of out-of-pocket costs to low-income families. Finally, not really surprisingly, but ironically, affordability problems are the biggest problem for people when they get sick. In particular, individuals who are older, have an activity limitation, a chronic condition like diabetes or heart disease, are most likely to be underinsured. And if they don't get coverage through an employer-sponsored health plan, or if they lose this coverage, they're going to have one heck of a time getting it from a non-group market that systematically denies coverage, limits benefits, or charges excessive premiums to individuals with pre-existing conditions or whom insurers believe are likely to need health care. Now, I've been talking here about money problems, but we all know that health care is a problem, affordable health care is a problem of your money and your life. There's lots of evidence, and the Institute of Medicine has come out with a new report documenting once again that with people without health insurance are more likely than people who have health insurance to delay care, to get less care, and actually to die when they get sick. Sadly, evidence suggests that increasingly people who are underinsured are facing similar problems. As one report shows that they are postponing care, skipping recommended medical visit or treatment, not filling prescriptions, and skipping doses or cutting pills. The underinsured not only struggle medically to survive, their medical struggle, as we've heard from some of you and you're hearing from your constituents, is forcing them into bankruptcy and increasingly into foreclosure. Even people with insurance just can't afford to get sick. But we're gathered here today to address this problem, and Mr. Chairman, we are counting on you in the coming months to do exactly that. So let me give you 4 principles to keep your eye on as the committee and the Congress moves forward. First, keep your eye on families' total health spending, as Dr. Reinhardt said. Not just premium contributions, but also on deductibles, cost sharing, and spending for other services. You've got to watch out for a desire to keep those premiums low by keeping the cost sharing high. The result is going to be insurance that doesn't work when you get sick. Second, and related, remember that benefits matter. Health insurance worthy of the name has to work for people when they're sick. So despite claims that I've heard, and I'm sure you've heard, that any insurance is better than no insurance, insurance that leaves people without the ability to buy the services that their doctors and practitioners prescribe is just not good enough. Like members of Congress, all Americans need adequate benefit packages with a defined set of services. It's a critical linchpin for affordability. Third, affordability clearly depends on income, and low-income families need special protections. And finally, insurance must stop discriminating against sick people. As long as insurers can deny coverage, limit benefits, or charge higher rates based on people's age or health status, insurance is going to remain unaffordable for people who need health care. Meaningful health reform cannot fail to ensure that health insurance is affordable for people who have been or whom insurers believe are likely to become sick. We know that enacting health reform is a challenging task, but now's the time. I commend you for your efforts and look forward to working with you to get affordable coverage for every American this year. Thanks.
Thank you, Dr. Fader, and thank all of you really for your statements. Now, the way we work it, we have questioning now from members of the committee, and I'll start by recognizing myself for 5 minutes. And my question really is to both Dr. Reinhardt and Dr. Fader. I'd like to get your thoughts on the addition of a new public plan, which you actually did discuss, a new public plan to the menu of healthcare tools available for expanding coverage. Obviously, we want to build on existing programs like S-CHIP and Medicare and Medicaid, but the fact remains that with 46 million uninsured people in this country, we will need to build significant new capacity in our insurance system. Now, you know, we've talked about having the government do a healthcare marketplace. Massachusetts is sometimes cited as an example where the government would go out to private plans and, see what their benefits are, their premiums, perhaps negotiate both those standards and premiums and offer group plans to people as an alternative to the individual market. But in the context of that, is this possibility of an option to enroll in a new quality, affordable public plan. And the goal of that would be to create healthy competition with private insurers, lowering overall costs and at the same time expanding access across the healthcare system. So I wanted to start with Dr. Fader and ask what you think about creating a new public plan, and is that a good idea in the context of some kind of health marketplace, national health marketplace?
Mr. Chairman, I think you've posed the question exactly right. It's very important to remember that what you've put forward and what's being talked about is a choice for Americans, and choice of private and public plans, not characterized as a public takeover or Medicaid for all. That's completely incorrect. We're talking about choice. And the importance of that choice is actually to set a model. Insurance companies are no model for running this system efficiently, private insurance companies. And they are not getting us good deals and getting us adequate protection. So establishing a public plan that is a choice and that operates on a level playing field with private insurers can actually serve as a push to get more competition. I think competition is a goal that all of us have, effective competition to get efficiency in the healthcare system.
Okay, thank you. Dr. Reinhardt, do the experiences of other countries that have successfully built universal healthcare systems suggest that a new public plan could be helpful to America, to the U.S.?
I think certainly it could. Not a lot of countries actually have this sort of mixture. The only one that comes close is Germany. They don't really have a public plan, but they have privately managed sickness funds, nonprofits, that work a little bit like Medicaid managed care, where the government collects the taxes, essentially, but lets private competing health plan purchase the health care, but under unbelievably tight regulation. So it almost is like a government plan. I, too, share the view that if choice is the mantra, and many Americans really do like choice, then having a public plan that people might like seems to be something that should be done, because by what rights would one deprive the American people of a choice they might favor? Now, where would I get this idea that they might favor a government plan? Well, two. The first one is we do have Medicare, and the elderly have a choice to go into private health plans or to stay in the government-run plan. And I don't know what I think 75% still choose the government plan in spite of the fact that the private health plans the taxpayer pays them 14% more to be able to offer a benefit. To me, that suggests there is a strong latent demand among the American people for a private health plan. And then people say, well, that's socialized medicine. And I would urge the committee not to use that term anymore. And the reason I do is I'll tell a little vignette. People will tell me, oh, socialized medicine is just terrible and it's awful. And I always say, okay, I'll accept it. Why do you not like my son? And then they look, what have you got to say about my son? I say, my son is a veteran, a decorated U.S. Marine Corps veteran with a Purple Heart. And yet you give him socialized medicine called the VA. So why do Americans run down this concept of, we're not even talking socialized medicine, we're talking about social insurance, run it down and yet give the very contract to their veterans, and I am a father of one. And I'd like sometime if somebody in this room write to me and explain this paradox to an immigrant like me. Why do you give veterans socialized medicine when it's so bad?
Thank you. Mr. Deal?
Thank you, Mr. Chairman. As I indicated in my opening statement, transparency of pricing is important to me, and I have introduced a bill, and I'd like to give you some of the components of that and see what your reaction to it would be. First of all, the bill would allow uninsured patients and other patients who pay out of pocket for certain health care costs to be able to go to an HHS website, enter their family's income and the health care services they need, and find out the prices they'll be charged for these services by all of the health care providers in their area. Second, it would allow doctors and hospitals to use the same website to find out what a particular insurance company will pay them for a particular item or service before it is delivered, and it will allow these providers to find out what their patients' copays will be. Third, it would allow the insured patients to make better informed decisions by allowing them to use the same website to find out what their copayments would be for particular health care services in their area, depending on who the health care provider was. And finally, it would require HHS to publicly disclose all of their Medicaid data in a way that protects individuals' privacy, but allows the public to join in the fight against Medicaid fraud and allow patient advocates to make sure that Medicaid patients, for example, are getting the care that they need. It would allow citizens to know whether or not young children who are enrolled in their state's Medicaid program are getting their well child checkups, and whether older patients are getting their annual cancer screenings. Would a piece of legislation like that be something that each of you might support? And I'll just ask you individually. Dr. Reinhardt?
As a general principle, price transparency is essential if you ever want to have models based on choice and competition. And of course, the health system has been uniquely opaque in this regard. Now, there is a problem with posting prices. Hospitals' charge masters have close to 20,000 items in it, and a physician fee schedule has 7,000 items in it. So prices would have to be reconfigured to be 4 complete procedures. I had in a paper proposed in Health Affairs that maybe the way to go is to say, let us use the DRG system for all patients, no matter who the insurer is, because it is a relative value scale. But each hospital has the right to set its own conversion factor to monetize the thing, and they have to advertise that. Then only one number would give you the prices of a hospital. Or one could have research that bundles all the services that go into a treatment like a coronary bypass graft or a hip replacement, and then give you the price per procedure with everything bundled in. But I think the idea of transparency is one I would wholeheartedly support.
Thank you. Ms. Pipes?
Yes, and I, too, support price transparency. We have price transparency in most aspects of our life, whether it's what phone service we use or what bank we use. I would be against government mandating price transparency. I think, in consumer patient-centered health care, we will see, if we encourage that and support it, I think we will see price transparency, because when you put doctors and patients in charge of your health care, prices will be negotiated. I think if we change the tax code, as I mentioned, so that individuals can buy health insurance, as Ms. Eshu said, on the same level playing field that those who get the tax benefit through their employer-based coverage, I think we will see much more competition. We will see new entrants into the insurance market, and when we have more competition, we will see prices being negotiated. I think even in Medicare, we could open up to empowering Medicare patients and doctors, and we will see people negotiating, and we will get price transparency as we have in all other aspects of American life.
I take that as a qualified yes.
Yes. Yes.
Dr. Fader?
I think that your proposal, Congressman Deal, makes a great deal of sense. I haven't seen it in all its details, but the transparency in getting inside the black box of insurance is critical as a customer, as a taxpayer, every other way. And so I applaud your efforts, and I'm happy to be of what help I can.
Thank you. Let me explore very briefly, because my time is running out. If we go to a government option proposal that would be offered as part of a package, would you anticipate that that government option would also have to take into account state mandates on what must be offered, which vary obviously from state to state? And would it also therefore take into account community pricing? And if it does all of that, don't we wind up with a system where a public plan would cost significantly more depending on where you lived? And how do we deal with that inequity in terms of explaining that to the public? Or would it simply be a uniform premium that you would anticipate that public plan would offer?
So I pointed that out in my testimony, that things like guaranteed issue, community rating, and a lot of mandates add significantly, 20 to 50%, to the cost of a premium. And if within this national insurance exchange there is going to be a public plan and all of those things are going to be added onto it, you're right, we're going to see the cost of insurance go up rather than going down, and that is going to crowd out more people out of getting covered and reducing that number of uninsured. So I would, under the health savings account, patient-based health care, it's not for everyone, but we have seen prices come down, as Mr. I think Burgess mentioned. We've also seen that people who have HSAs are 30% more likely to get an annual checkup and be engaged in prevention because they don't want to be facing significant costs once they have a degree, and that work was done by McKinsey and Company. So I think we have to be very careful. I'm very worried. New Jersey, New York, Massachusetts have community rating, guaranteed issue. Their insurance is very expensive, and if we do this plan, it's going to crowd out private insurers, and that's my main concern.
I'm sorry, I can't have any time. I've already exceeded my time, and I'm afraid I can't let the rest of you answer, but maybe we can get to it later. Thank you.
Thank you, Mr. Deal. Ms. Eshoo?
Well, I want to thank the witnesses, each one coming from their own place and stating their case really forthrightly. I enjoyed your testimony, and I think that while I might not agree with everything that I've heard, I like the way you have framed it and presented it to us. Since today is St. Patrick's Day and the one day where we're all Irish, Ms. Pipes, or is it? Yeah, Pipes. You quote P.J. O'Rourke, and you say, if you think health care is expensive now, just wait until it's free. Where in anything is anyone talking about free?
Well, Michael Moore...
I mean, where does this come from?
Well, because people, like as Michael Moore said in his movie Sicko...
No, we're not talking about movies. We're talking about reality.
Right.
So when you say in congressional testimony, if you think health care is expensive now, wait until it's free. Who has suggested that health care is free? We are faced with 12 and 14% increases every year. It simply is unsustainable. We know that people are left out. We know that it's a system that's fractured. We know that we're spending too much as a nation and not getting back for people what they should have. And so I really think that the notion to say just wait until it's free is, it really doesn't belong here. I feel strongly about that. I don't know if you might not regret having said it, but I don't think it's really part of this. Now, I mean, you can defend it, but
Right.
do you have a defense for it?
Yes, sorry. So thank you for that comment. The reason, what it means is when government takes over the supply of health, the total supply of health care, people think it's free because they're
Well,
not
we can get into a
directly.
real debate here. This is not a discussion about the government taking it over. This is about the government rewriting the rules of this because so much of it is not working. And we know that it's not. Insurers say that. Families say that, and so there's consensus on that. So now, let me move on and just ask a few questions. I really want to kind of drill down on this whole issue of tax treatment. And while this is not the Ways and Means Committee, you're all experts, and I really would like to hear your views on this. And what your opinions are on the tax treatment of employer-sponsored insurance plans. As you know, those who get their insurance through work pay no tax, while those that purchase insurance without a group plan do. Do you think that all plans should be taxed? Do you think they should be taxed in part for certain services? What's your view on all of this? It's not a subject matter that's often discussed, and I'm curious about it. So, Dr. Fetter, do you want to start?
Sure. You raised it in your opening
Right.
remarks. It's concerning to you, and our employer-sponsored health insurance has grown up. And the development preceded the special tax treatment, but that has strengthened it. And there is a concern about inequities because better off people get a better break than
Right.
low-income people, and certainly than low-insured, because it varies with your
Sure.
tax bracket. And so there are concerns about that. But I am very concerned about doing anything that undermines the employer-sponsored health insurance system, because although it's got significant limitations, it does create the groups. And you talked about assuring access to group insurance. It creates those groups that enable us to pool risk rather than having everybody on his own, which we see in the non-group market. So I think that there are concerns about it. I think as we develop a system, we want it to be fair and shared responsibility, whether it's through the tax system or other mechanisms for everybody. But I am very concerned about proposals to eliminate the tax break, because it essentially does undermine the insurance system, the employer-sponsored, and also anything that would shift, that make it come apart and throw everybody into the non-group market.
Thank you. Dr. Reinhardt?
Well, almost.
Oh, you posed a question about socialized. It's a political phrase to scare people.
Yeah.
That's what it is.
Yeah, but it's
a bumper sticker.
It's really peculiar when you.
It is peculiar.
When you're the father of a veteran to have that.
Well, how about members of
bad
Congress
thing.
receiving Social Security?
Yeah, or that.
Yeah.
Or bankers.
Right.
Who are on Social Security, as you know. No, the issue of taxing employer-provided benefits, most economists, in theory, would be for that. But there's always the concern, and I've written a paper on a balance sheet for employment-based insurance. At the moment, it's the only really functioning risk pooling mechanism in the private sector. And actually, for all its flaws, has worked. It served Americans reasonably well. So an alternative might be to go and say, well, self-employed people should have the same tax privileges. I don't think tax-wise it would cost that much money, and that seems fair to do. But there still is an issue of giving people in high-income brackets a bigger tax break than in low-income brackets, which you really sense with a flexible spending account, where when I get a tooth drilled, it costs me half, and a gas station attendant pays 85 cents on the dollar. So there are ways to deal with it. For example, one could say, harvest some of the money. I'm a full professor at an Ivy League university. I really don't need this tax break to get health insurance. I could be asked to pay taxes on it, and I think I would. So you could say, if you're making less than $75,000, you won't be taxed on it. If you make between 75 and maybe 150, we'll take half what the employer pays and add it to your W-4. And if it's over 150 or over 200, the whole thing is taxed. Then you say you're punishing the rich. Well, I don't consider that punishment. I consider asking me, who is so lucky to have a tenure job at Princeton, to pay for my own health care. I don't call that an imposition. I don't really need that subsidy from the gas station attendant, which I now have. So that is one way you could harvest some of the money without hurting the rank and file.
Thank you very much to each one.
Gentleman from Kentucky, Mr. Whitfield.
Thank you very much, and thank you all so much for your testimony today. We appreciate it very much. When we think about Medicare, Medicaid, the VA, S-CHIP, we know that represents about 48 or 49% of the total health care delivery system in the U.S. And we view those, I think most people view those as government programs, which is providing a valuable service. But we also know that those programs are contributing greatly to the escalating cost in health care. Every time you visit with the Concord group or a lot of groups, they say with Medicare increasing cost every year and Medicaid increasing cost every year and Social Security increasing cost every year, that we're going to have a financial disaster 22, 23, 24 years down the road, on top of our already economic crisis that we face today. So when we talk about reforming health care, I think many of us on this side of the aisle view it as the government taking it over. I mean, and the government already runs Medicare, Medicaid, S-CHIP, the veterans' health care system. And I know, Dr. Reinhardt, you mentioned that I think I had to leave during your testimony, but I think you said we need universal health coverage. And Dr. Fetter, I don't know that you said that, but I believe you set out certain principles that you had to consider to
And I do favor universal coverage.
Yes. So if the government plan that's in operation today, I mean, the ones that I mentioned, the costs are escalating every year. We can't control those costs. If we allow government to be basically responsible for the other 50%, why are we encouraged that that government could control those costs better than the way we're controlling costs today?
Well, Congressman, that I don't think we are proposing having government take over those other costs. And I actually think as you look at the share that government is spending, some talk about it as shifting from the private sector to the public sector, because our public programs are taking care of older Americans, disabled Americans, and Medicaid. The bulk of the spending in Medicaid is for people with disabilities and older people and long-term care. So they have particular responsibilities and have left the healthiest population to the private sector. And when you talk about the overall cost growth, we have lots of evidence, and I know that former CBO Director Peter Orszag presented that to you as CBO Director, and now as OMB Director, he makes the same point, and that is that our public health insurance programs are not growing faster than the cost of health care in general. Everybody's buying in the same market, although Medicaid really buys on the cheap.
Yeah.
But the costs are growing in general, so that the only way to get a handle on the growing costs, which you rightly recognize, of Medicare, Medicaid, veterans, any health insurance program that we have, is to pursue slower cost growth through investment in primary care and prevention and a host of other mechanisms that affect the entire system, and to make sure that everybody's got coverage all the time so that we can promote prevention and better treatment.
Now, you know, as you were talking, and Dr. Reinhardt, I'll give you an opportunity to reply also, but as you were talking, another government program that I think has worked very well is the community health centers. I mean, I think the community health centers addressing the primary health care issue have worked very well, and basically they're paid for by the federal government working with local entities. And I always thought that community health centers are in a partnership in the private sector with gigantic employers might be a way to expand accessibility too.
Well, I share your view of the excellent performance and the value of community health centers, and they certainly are a part of the system in making sure that, as many have said, people don't just have access to health insurance, they have access to care. But the community health centers, unless people have insurance coverage, they face tremendous problems once anybody gets beyond primary care. They can't find specialists. People need insurance coverage.
Now, Dr. Reinhardt, if you'll take about 30 seconds to reply, if you can, then I want to make one other comment.
Yeah, the first point I want to support, if you look in November '07, Peter Orszag published a beautiful report on health care cost growth. And there's figure 4. You can actually really see how each sector, public, private, is growing. And in fact, on a per capita basis, Medicare has grown less rapidly than the private sector. On the community health center...
On the cost of it?
On the cost.
Okay.
And you have to do it per beneficiary, and Marilyn Moon has done a lot of research. And that's well understood. On the community health centers, I think they are an important part of the landscape in American healthcare because they're so accessible. And they do a great job for the money they have used. But we had a commission on rationalizing New Jersey healthcare and looked at these centers, and this theme that they are great in primary care, but then they're not multi-specialty. Getting access to specialists was the Achilles heel. So yes, I think we should have them. They should stay, and the Congress might worry about how to have a larger range of services provided.
Right. Mr. Chairman, I would just make one other comment. Another thing that bothers a lot of people, though, when you talk about universal health coverage and you think about the Canada system and the Great Britain system and so forth, and Ms. Pipes went over this in her testimony. Maybe you all can address it later, but if it is true 750,000 Canadians are waiting for procedures, and 3.2 million out of the population are waiting to get a primary care doctor, and Canada average wait for seeing a primary care doctor for getting treatment by a specialist was 17.3 weeks, and the rationalization of health care, that is a real concern to a lot of people. And you can't respond to it now, but later on, I'm sure we'll have an opportunity to address that in more detail. Thank you.
Thank you. Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. And following up on my colleague from Kentucky, I have a district, a very urban district in Houston. It's an underserved district. We have actually 4 community-based health centers, and they're in financial trouble right now because so much of that we depend on is foundation funding. And foundation funding, because the economy is cratering. So we need more of them, but we also need to look at our authorization levels. That we upped the authorization, our 5-year authorization last time. Even with the stimulus money that was in there, in the Houston area, the 4th largest city in the country, it helped 2 of our FQHCs. So I don't, that's, we need to do better on the community-based health centers, and hopefully whatever plan we have will make them where the rubber meets the road, literally, for the uninsured and the underserved. I mean, it's a great program. It's been around for almost 50 years now, I guess, since President Johnson. And I'd like to ask the panel that how do you see these FQHCs because of the, my problem is the disparity of the location. Great example, Chicago is fortunate to have 81 community health centers, and in Houston, Harris County, we have 10. And we're trying to create more, even though we're the 4th largest city and may pass Chicago in the census. But how do we create, we have a disparity in where these centers are located because of the local networks.
It seems to me, Mr. Green, and I'd have to look into it further as to what the problem is under the current circumstances, but the best way that you can promote those delivery systems is to get everybody health insurance, because then every patient who comes into a community health center is carrying money. They're not dependent on a federal grant. So the bottom line is that we need health insurance in order to enable delivery systems to prosper.
Well, and the problem FQHCs have is just like problems hospitals and doctors. You have a lot of uncompensated care.
Exactly.
Even though people have to pay something, they don't pay enough that covers the cost of the
Right,
service.
and valuable as they are, and as Mr. Whitfield said, is that even expanding community health centers is not a substitute for getting people insurance. They're a valuable part of the delivery system and should be supported by everyone having health insurance coverage.
I'd just like to add that I support community hospitals, and Michelle Obama, during the campaign, said, being at the University of Chicago, people shouldn't be turning up at the University of Chicago emergency rooms for very, very expensive care. She supported the community hospital. So that was a very good point. Just on a point on the hidden tax, people keep saying that the uninsured are adding a tremendous burden to the cost of those who have private insurance. The work done by Dan Kessler at Stanford, he shows that the uninsured are adding about 1% to the cost of premium for those who have private insurance. The 10% cost addition to private payers' premiums comes from Medicare and Medicaid, from the lower reimbursement rates paid by the government. So I think that we really need to focus on, how if we're going to go down the path to more Medicare, more Medicaid, expanding these programs, reimbursement rates are low, and as we see now, 1 in 3 new Medicare-eligible patients is having trouble finding a primary care doc. Because in systems like Canada, when the government took over the health care, people talk about there'd be a lot of increase in primary care. But in fact, med students didn't go into primary care because when the government determines how much you're paid, they would rather go into specialty. So that's why we have a tremendous shortage in Canada of primary care docs.
Well, I'll give you an example, though, that FQHCs, doctors can make a decent living there. You can get $135,000 or family practice in a community-based health center. The problem is it's not, not the specialties, and we know how high the specialties are. Dr. Reinhardt?
I would want to stress Dr. Fader's point. The important thing is to endow people with purchasing power to get health care. Because the trouble with institutional grants is you can have community health centers that are angelic, they have this budget, and you have others that are not. And to get performance is measured is not easy. But when customers can walk, competition will actually take care of it. That's why, in general, community health centers as a delivery device are good. But I think it would be good that if their clients brought their own purchasing power with them. On this issue of cost shift, this is actually an interesting thing. People who believe in markets should not believe, in my view, that just because Medicaid or Medicare pays hospitals too little, private payers have to pay more. That's not true in a hotel. If somebody gets a discount, they don't call you up in the middle of the night and say, hey, Smith just registered. We gave him a discount. We're going to raise your rate. So if you actually believe the private market works, why are private insurers not following Nancy Reagan's advice? Just say no. Well, we're not going to take it. So I don't believe this cost shift story of private payers picking up what Medicare doesn't pay. I don't believe in that story.
Well, Mr. Chairman, I know we have a situation in our country. Medicare pays so much, Medicare actually pays less. But in some cases, if you have a military base, you ought to see Champus and TRICARE don't even pay what Medicare makes in reimbursement. And we've run into that problem in a very urban area with our number of activations. So you're right. We need to look at the reimbursement rate to make sure they actually do fit the cost of the service. Thank you, Mr. Chairman.
Thank you. Gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. Let me just ask a question. I hate to do this because it's beyond the scope of this panel, but Mr. Green brought up in his opening statement that Texas has 25% uninsured. When Massachusetts did their program several years ago, they made a decision that they were not going to factor in, or they were not going to include in their factoring any cost for people who were in the country without the benefit of a Social Security number. Of the uninsured in Texas, there are a significant number. We could never ignore that number of people who are in the country without the benefit of a Social Security number. So we failed on several attempts since my short tenure in Congress to deal with this issue. Can we really get to the point where we're talking about the type of reform that you three are discussing if we don't deal in some way with the problem we have with immigration and people who are in the country, again, without the benefit of citizenship?
Well, I served on the board of a Texas-based hospital company, and we had this very problem. On the front lines, you cannot tell when people come in bleeding or pregnant, about to deliver. You cannot send them away. So we serve them one way or the other. Anyhow.
So in fact, you're required to under federal law, under EMTALA.
EMTALA, yes. And in New Jersey, it's even more. The whole thing has to be delivered. So most of the immigrants are actually working or have families where somebody works. And it seems to me we have let employers in this country off the hook much too easily. They should pay for the social services that the immigrants and their families consume, whether it's schooling or they should be made to pay Social Security. And that includes even people who do shrubbery, as they do in Princeton. One ought to be required by law to pay a prorated contribution to these people's social services. But we've never actually done that. There are quite a few people who employ undocumented aliens, pay nothing into Social Security, and get away with it. They have them as subcontractors, and God knows. So, yeah, I think you cannot not give health care to these families, particularly the children, because whether you like it or not, these children will one day be Americans.
Well, many of them, in fact, are by virtue of the fact of
that they were born here.
They were born here. But I'm not seeing from congressional leadership or from the White House any serious attempt at dealing with this issue. And I just think I take the points, I stipulate the points you made, Dr. Reinhardt, are accurate, but it's just going to be very, very difficult for us to deal with this issue when we've got that larger looming problem in Texas, New Mexico, Arizona, and California, where it is just going to be very, very difficult to overcome.
Well, there is the moral hazard problem. If you make health care, this great American health care, available to people, people will flock here ever more.
And that was the argument.
That is the moral. That is why the Congress sometimes says, let's not do this, because we're creating a magnet. But
well, we did that in SCHIP. We essentially said that we were going to remove some of the barriers, and we've turned off the jobs magnet to some degree, but we have to be careful not to turn on the benefits magnet.
In the end, there is a doctor and a nurse and a hospital looking at this human being, and they cannot say no.
Dr. Reinhardt, I will just stipulate that that is correct, and practically every night of my practice life, I was called to do such a delivery because EMTALA said I would have a $50,000 fine and some serious questions to answer if I did not respond within 30 minutes, and yet at the same time, that same federal government failed to protect, secure the borders, and as a consequence, we in the hospitals are left on the front lines of that. I didn't mean to get so far down to that. I did want to ask a couple of questions about the federally qualified health center issue that Gene brought up. Mr. Green brought up, because it is, the distributional issues are significant. While he has 4, or what did he say? How many did he have in Houston? It's way too many, whatever he said. We only have 4 in Dallas County, 1 in Tarrant County, none in Denton County, where I represent significant numbers of people. The infant mortality rate in Tarrant County in some of the zip codes is phenomenally high, and we only have 1 federally qualified health center, not in the neighborhoods where those zip codes exist. So there it's not a question of access. We've got a good county hospital in Tarrant County. The question is utilization, and we have not put the clinics where the people are so that they will use them, and that is one of the great inequities. I've often wondered why we reimburse at a higher rate for Medicaid reimbursement at Federally Qualified Health Center, and we won't do the same thing for a physician in practice in the community to keep that physician involved and in practice. So, Dr. Reinhardt, you almost went there with the money should follow the individual. Can you expound upon that just a little bit?
Yeah, I think in general, certainly in my profession, economics, we believe in competition, and therefore, whether it's scholarships, it should never be given to a medical school or a university. It should travel with the client. And that is why, ideally, people should have the same insurance. A doctor should get paid the same, no matter where they work. You're reimbursing a professional service, and it shouldn't really depend on what location you do that in. So I sympathize very much with your thought.
And what is a mechanism that money could follow the individual?
Mr. Burgess, you're over. This will be the last question.
Universal insurance is, in fact, the mechanism. That's why some of us are so much for it, that if people have purchasing power, like a Canadian has a credit card, and with a credit card, every doctor gets paid the same, whether it's a poor child or a rich child. Well, in New Jersey, we pay Medicaid $30 for a pediatric visit, and for the commercial, $120. Canadians don't do this. This is why I think the Canadian story here is not really relevant to us at this time. They have a different social ethic. They look at life differently than we do. If you did a survey now in Canada, Canadians are not stupid. They're highly educated. They watch American TV. They have a democracy. And yet, if you had a referendum whether they would want our system or keep theirs, overwhelmingly, I would bet a lot of AIG stock on that. Overwhelmingly, you would find, well, it's still worth something.
Yeah.
We'll see to that, actually. We'll stipulate that.
I put real money on it, real New Jersey money. The Canadians would vote for their system. There are, of course, some who are not happy, and they can come here and do research. But by and large, when I go up there, I'm a Canadian too. When I go up there, by and large, people are very proud of this system, and I invite you to do it. Go to the airport, talk to anyone.
Yeah, my father was a refugee from Canada. So
all right, we've
understand.
got to move on here. Next is Ms. DeGette.
Thank you, Mr. Chairman. Dr. Fader, I was wondering if you wanted to respond very briefly to this issue of the undocumented immigrants coming in and and taking advantage of our system.
Thank you, Ms. DeGette. You saw me chomping at the bit.
I did.
I'll be brief. I just wanted to make very clear that although immigration is a very serious problem that does create serious problems for health providers, particularly in some areas, that the problem that we're talking about is we should not ever think that the bulk of people without health insurance coverage or the bulk of people who are facing affordability affordability problems are immigrants, whether they're here legally or not legally. And I also believe that when we're talking about, we asked about universal coverage, we are talking about universal coverage for people who are Americans and are here legally. And I just didn't want that issue to get confused.
If you were structuring the universal health care program, you wouldn't necessarily structure it so that we were inviting people to come in.
I think that's absolutely true. And we have seen that people, as Dr. Reinhardt said, people are coming here as long as employers want to hire them and we don't enforce our rules.
Right.
And with the decline in the economy, they're not coming in those numbers anymore. So I think that we should, although it's a very serious problem that I wouldn't minimize and faces some institutions in particular ways, it would be a mistake to hold the whole healthcare system and all Americans hostage to that problem.
Thank you. What I really want to talk to this panel about is this issue of a public plan alternative, because I think that, frankly, as we move forward with drafting legislation in this committee, that's going to be one of the top issues of discussion and debate. And some people say, well, we shouldn't have a public alternative, I guess because it leads us down a slippery slope towards socialized medicine or single payer or so on, but we actually do have one of our largest public health care systems right now has a public option and a private option, that's Medicare. And the Medicare fee-for-service option is the most popular option, and people like that. But more importantly, I think, if we didn't retain the fee-for-service option when we did Medicare Advantage, we would have never realized that we weren't getting more efficiencies in the private option that we had adopted. And frankly, I was here when we did Medicare Advantage, and I thought that when we did the private alternative, that it would save us money and it would cause us to revamp our fee-for-service program to get more efficiencies in that program. We all know now that, of course, that has not been the case, and that we're spending far more in the private alternative than we would have in the public. And so I guess maybe, Dr. Fader, I'll start with you. I'd like your comments on why you think it's important to have a public option if we're going to maintain the private competition that we have.
Yeah, I think you nailed it, Congresswoman DeGette, when you said that essentially the public system can keep the private system honest. But we have evidence that private insurers are not negotiating effectively in terms of getting affordable health care. And if we have a public health insurance option, remember, because I think it gets misrepresented as a choice, then the public can hold that plan accountable for bargaining effectively with providers, for delivering quality care, for being transparent, for all the things that we need insurance to be. And essentially, it puts some pressure and makes a market that claims to be competitive but is not. It can make it work.
And just to follow up on something, Ms. Pipes, I never try to misconstrue what people who I disagree with say, but what I had heard Ms. Pipes saying is part of the way in Medicare and part of the way it would happen in this system that you would get the efficiencies is by ratcheting down reimbursement for medical services, and doctors wouldn't want to provide those services. What would your response be to that, Dr.?
Well, I find these claims fascinating at a time when the Congress is responding to concerns about physicians in the Medicare program, and responding to access problems by raising physician fees. And in Medicare, we make an extra effort to make certain that we're paying appropriately, but that when access problems arise, that we enact higher rates. And we are talking about then a responsiveness to people need access to care, and your constituents hold you responsible for that. So I don't think that this concern that somehow it's going to go to nothing or Medicaid for all is, I don't know where this is coming from.
Dr. Reinhardt?
Yeah, I agree. I served on the Physician Payment Review Commission, your commission, and we every year did a survey of the elderly and asked, do you have access to health care? And that's still part of what MedPAC does, and monitored it very, very closely. And we had rules of thumb when we saw access becoming even a small problem, we would recommend to the Congress to raise rates. So that in the Medicare program has, I think, been pretty well modulated. But there's another thing that really I find puzzling, particularly around the business roundtable. On the one hand, they complain that we're spending too much on health care. And then, on the other hand, though, they're saying the public sector isn't spending enough on health care. And then they also come out that government should stay small. And I sometimes, in my simple mind, try to put that all together. They say they want small government, but they want them to pay more for Medicare so that their rates are somehow viewed the correct rates. Who is to say that private insurers aren't overpaying, particularly since they have so little bargaining power? In some places, take California, even a large company like WellPoint cannot face down a hospital system. And who's to say the private sector isn't overpaying? I mean, you could make that case.
Thank you, Mr. Chairman.
Thank you. Gentleman from Illinois, Mr. Shimkus.
Mr. Chairman, I'll defer to whoever's next on this side, if I may, since I just want to listen.
Thank you. Mr. Gingrey?
Mr. Chairman, thank you. Ms. DeJette was just referencing in Medicare that we have a public...
With the gentleman, it's DeGette, and everybody's, including the president, has been saying it wrong, so I just like...
Ms. DeGette.
Thank you very much.
And it's Diana and not Deanna, is that correct?
You got it.
Thank you. I will remember that. But Ms. DeGette was talking about the public and private plan that we have within the Medicare system, and that the private plan is turned out to be so much more costly. And the reason I bring that up, because Dr. Reinhardt, in your presentation, you talked about the importance of rigorous cost-effectiveness analysis. And I have concern that our way of scoring things in a static environment rather than a dynamic way of doing it. Medicare Advantage, and the President, of course, has certainly taken a swipe at Medicare Advantage and is going to cut that significantly, and to the chagrin, I think, of 10 million people who get their care through Medicare Advantage. If it's true that end-of-life cost is the biggest cost of Medicare, the last month of life, then I think we might be judging that cost of Medicare Advantage prematurely. Now, I'm not saying that it should be 115% compared to Medicare fee-for-service. Maybe it is a little too high. But in the final analysis, it seems to me that if we looked at this in a dynamic way, follow it all the way to the end of life, then it may turn out that Medicare Advantage, the private versus the public, would be much more cost-effective. And I worry in regard to what you were saying, Dr. Reinhardt, in rigorous cost-effectiveness analysis, in regard to medications, in regard to biologicals, in regard to durable medical equipment or devices, that maybe, in fact, these would, by some a rigorous cost-effectiveness analysis, almost like a Federal Reserve Board for health care, that these decisions would be made too early, and if we had an opportunity to wait and see in combination with other things, whether it was a cancer drug or a new surgical procedure, that in fact in the long run it would be cost-effective. So I'd like for you to respond to that.
Well, I mean, first of all, your point of ideally we would like to have a dynamic view is correct. I agree with this. Ideally, what you would really like to have a natural experiment where some people went into Medicare Advantage, some stayed with the traditional program, and you could follow them till they die and say, what were the life cycle costs, adjusting for illness and so on. That would be ideal, obviously, and maybe you're right. It could be cheaper if they manage somehow the last month of life more efficiently. I'm not sure that there's any evidence.
Well, I would say this is very likely that those were managed efficiently over a number of years in regard to wellness and taking care of themselves and taking care of their medications. When it comes to be their final day on earth, it might be a catastrophic event like a heart attack or a stroke, but not in an intensive care unit for months suffering from multiple horrendoplasties, as we used to say in medical parlance.
No, it's possible. I mean, and it's researchable. One could research it even now. You could give the ARC some money, and I speak here with a conflict of interest because I'm a health services researcher, but we could research them.
Yeah, I think you could. And let me ask you one last question, Dr. Reinhardt, before my time runs out completely. You had an article published March 13th of this year in the New York Times. You pointed to two groups who comprise the, quote, opposition to cost-effectiveness analysis, unquote. And you said one of those groups were manufacturers of pharmaceuticals and biotechnology products or of medical devices. But the second group, and this is what I want to address my question to, you said the second group are individuals who sincerely believe that health and life are priceless. And you went on and you said in describing this second group, you state that for them, cost should never be allowed to enter clinical decisions. It is an utterly romantic notion, and if I may say so, also an utterly silly one. No society could ever act consistently on such a credo. That's the end of your quote. Dr. Reinhardt, do you believe that we as individuals in America should have the ability to value our own lives, or is this something we should ask the government to do for us, i.e. ration that care when you get to be 90 years old and you need a hip replacement? Do you just let them fall and break the hip and die of pneumonia, or do they get the opportunity, if they value that, to get that hip replaced?
I cannot even tell you, Congressman Gingrey, how much I hoped someone would ask me this question. Because this is how I would think about it. Every American should have the right to value their own life any way they wish. But then the question is at whose expense? If it is at their own expense, by all means. But if you are dealing with a collective insurance fund, then those who preside over those funds do have at some point to ask themselves, at what price do I buy additional life years, quality adjusted, we call them QALYs, or additional health? And to say, we don't make airports as safe as they could be. Our air traffic control system is reckless, I think, from what you read, in what often near misses. And why don't we do it? For over money. We may calculate. Our son fought in an unarmored Humvee. That was a calculated decision to say, well, it would cost so much to have armored vehicles, we're going to take a chance on the life of some Marines. And that's what the Congress does. So what I listed there is a paper that shows the value on human life legislators and people routinely put on their own life, and they are rather low numbers in many ways. And I raise the question, why should healthcare be the only area in an economy, in society, where I have the right to say, spend the limit, spend $5 million on me, and let the taxpayer pick up the tab? I think that notion, to my mind, is romantic and, in fact, silly.
We're
like a German philosopher.
Got to move on.
Just a year.
Mr. Gingrey, I'm sorry, but we just have a lot of people, and we got another panel. Next is Ms. Capps.
Thank you, Mr. Chairman, and I want to use my time really well with great panel, and I have a question for each of you, starting with Ms. Pipes. In your testimony, you talked a lot about rationing care and waiting lists, and Canada does have bad wait times, but so does the United States. 23% of adults reported having to wait over 6 days to get an appointment to see a doctor the last time they needed one. In the UK, which also has a single-payer system, it was only 15%. In addition, 34% of sick adults in America who had medical problems skipped important doctor visits because of cost. That's way more than the 4% in the UK and the 7% in Canada. Not to belabor that, because we're talking about American system that we want to try to reform, is there any data you can present to this committee showing that a new optional public health plan will create rationing times or wait times worse than what we're seeing right now?
Well, I haven't done the exact research on that particular issue, but I think
So there is
based
no
on
documentation that you know of?
Not that I know, but I can look into it and find that out.
That would be
because I
great.
think-
If you can
I
find
think-
it, I'd love to have it for our...
Because I think, you know, Canada does have long waits, and people that have money come to the United States and pay out of pocket.
You said that in your testimony.
So it's very important that we improve the U.S. system so that people can get better access.
Exactly.
And that's why I support universal choice, because a young man of 30, you know, wants to get a high deductible insurance plan. Why should he have to pay $12,000 to $15,000 to cover my in vitro fertilization? You know, I mean...
Thank you very much. And if you can find that information for us, I think it would help us to make some good decisions. Dr. Fader, I mentioned a story in my opening minute about a constituent of mine who lost her job and had a reoccurrence of her cancer. She did well in the county that I represent because they have a particular public access program that worked for her. But I want you to be able to elaborate briefly, but for our value, what you were saying about how when someone loses employer coverage, their ability to purchase coverage in the non-group market is limited at best.
Yeah, well, it is, you're absolutely right. In your community, she had an option. She had what is called a pre-existing condition. She was sick. And you're going to hear on the next panel from my Georgetown colleague, Karen Politz, who can give you examples, a tremendous number of examples of this kind, that people in the non-group market essentially does not either denies people who have conditions, rules out coverage for the body parts that have been damaged, limits the benefits, or charges higher rates. The market simply does not work for people. It's not any kind of safety net, and the evidence on the non-group market is that rather than people falling into that system and getting picked up, it ends up people are healthier in that market than in the employer-sponsored system. So this woman, without your plan, when she most needed care, would have lost any means to get access to it. And we know, looking at the evidence in general on the uninsured, that people are actually dying in that circumstance.
Thank you very much. And
people do, I mean, I think if we change, I mean, because people get their insurance through their employer and it's not portable if they lose their job, this is one of the reasons why changing the tax code so that people can go into the individual market. And also, I think we'll see more competition and new insurance companies that will deal with specific people.
We'll see about that.
They don't compete for sick people.
That's right. If there's anybody who can show a plan where they compete for sick people, we would love to hear about that too. There's another topic that's very dear to my heart, Dr. Reinhardt, I saved for you. In the United States, we spend nearly $7,500 per person on health care. It's the most expensive system in the world, if I'm not mistaken. Yet, in terms of maternal mortality, women dying in childbirth, we rank 41st out of 171 countries. So there's a disparity there. How can we now, as we want to reform our system, what are some proposals specifically that would improve issues like maternal health, a classic indicator, according to the Millennium Challenge, for the overall health of a nation, while striving for lower costs?
Well, obviously, part of the reason why women die has to do with issues outside of the health system, and every health services researcher would recognize this. But when you come to infant mortality or maternal death, the health system does have a contribution to make, and I think we're falling short. It's because people often do not have insurance, particularly when you're just slightly over the Medicaid limit or live in a state with a low threshold. And I must say, as a European and ex-Canadian, I'm stunned at this. I believe the children are the treasure of a nation. They're the future generation. And I always have said, to me, mothers are on par with soldiers. They do a patriotic service because they bring us the next generation. We should give them medals rather than the way we treat them. And I remember I once gave a speech called Motherhood and Apple Pie, where I said, I do buy the idea that Americans love apple pie, but I'm not so sure about motherhood. I don't think in this country we respect mothers enough, and I have people who know me know that's a big deal with me. We do not respect mothers enough.
It'd be worthwhile you looking at some of the work that June O'Neill has done on infant mortality rates, because other countries, we have the best neonatal procedures and clinics and facilities in this country. And often in other countries, people are not counted as live births. And so look at the work that June O'Neill has done, because you have to compare apples with apples.
I was talking about maternal mortality, but
Right.
our infant mortality rate's not so hot either.
Well, but I think you have to compare on an equal playing field how other countries treat what they just count as infant mortality rate versus this country, because we keep a lot of babies alive that wouldn't even be counted as live births in other countries. So it's very important. Look at June O'Neill's work on this issue.
Thank you. Next is the gentleman from Arizona, Mr. Shadding.
Thank you, Mr. Chairman. Ms. Pipes, I'd like to begin with you. I think I've heard you describe what you favor as universal choice. Are you familiar with plans that have been introduced that would provide every American with a stipend that is either a tax credit or a refundable advanceable tax credit that is cash to go buy a health care plan for every single person? Are you familiar with those, and would you describe that as universal choice?
Yes, I would. And Mr. McCain during the campaign was sort of hit by Mr. Obama saying, Mr. Obama said Mr. McCain would like to tax your health care. Well, in fact, the plan would be...
Well, I don't want to talk about his plan. I want to talk about some quick questions, and I've got a long list.
So, but I think it's a
Would
good
you
idea.
say that we have a patient choice-driven system now?
No, I would not. I would say 47% of health care is in the hands of government today, and we have a small sector. 7 million people have patient-centered health care.
Would you include in that patient-centered health care plans that are picked by your doctor? Don't we really have a third-party control system in America today where your health insurance plan is picked by your employer and the plan then picks your doctor and you have virtually no choice?
Absolutely. And that's why if we can move away from employer-based care and move up the individual market, people will be, new competition will come in, new insurance plans will be available, and people will be able to choose the type of plan that fits their individual.
What if we let them choose from the private market or choose their employer's plan, but put the choice with them?
That's an excellent idea, yes.
Would you say that we would have a healthy market in health insurance in America today?
No, I would not.
This represents the Northern Virginia residential phone book. All of the people in that book get to buy auto insurance if they have an auto, right?
Right.
If I put up here the Northern Virginia business phone book, it would be a fraction of this size, would it not?
Yes.
Maybe a fifth or less. That would represent kind of a graphic of the health insurance market versus the auto insurance market today. That is, only employers get to buy health insurance, and they make the decision for their employees, whereas in auto insurance, everybody gets to make their own choice and gets to pick a plan, and we have a much healthier market. Wouldn't you agree?
Absolutely. And, you know, if the average employer spends $12,000 per year on an employee's health plan, maybe even $15,000, but the thing is that not all employees need that much health care, and there would be more competition if people could choose, like in the auto insurance, the type of insurance that fits their needs, and some will be a lot cheaper.
So you would favor a system where they get to make their own choices?
Absolutely.
And moving away from a system where there's a third-party control?
Right.
I take it then you would not agree from moving from a system that is third-party control by your employer to third-party control by the government. Is that going to solve the problem in your view?
I think that if the government takes over the healthcare system and including this public plan within the National Insurance Exchange, it's going to reduce people's choices, costs are going to go up, and ultimately care will have to be rationed, as it is in countries like Canada and the UK.
Dr. Fetter said, and I agree with her, that affordability is the real key here. We're worried about expense. We're worried about how expensive health care has become,
right,
and how expensive health insurance has become. Do you think it's a coincidence that we are experiencing a huge spiraling cost in health care costs where it's all third-party control and the market doesn't include all these people, it just includes this little business phone book, that we are only experiencing that spiral in cost in the one place in America where there is genuinely no market? Is that a coincidence?
Well, as you have said, I mean, we don't have a free market in healthcare. We have a lot of government in healthcare. We have the third-party payer system, and people are not in charge of their healthcare. We don't get our life insurance, our long-term care insurance through our employer.
We've pretty well divorced the consumer of healthcare services from the payer of healthcare services.
Absolutely.
And once divorcing them, costs have gone up dramatically. once we've divorced the consumer from the payer.
Because we have in this country what you call first dollar coverage. When people think they pay nothing, if employees don't pay anything for their premium, or they pay a little bit, or they pay no copay or a small copay, first dollar coverage means when people think something is cheap or free, they demand a lot more of it.
And they think it's cheap right now because their employer's paying for it.
Yes, and then
let me switch topics. A lot of discussion here today about a public plan. If we institute a public plan, won't politicians have a tendency to increase the subsidy of that public plan year after year after year, as they've done with other public offerings?
Well, I think if you look at Canada, when the government took over the health care system in 1974, they were completely taken aback by how much demand there was for a program that people think of as virtually free, because they don't know how much they're paying through the tax system. And it went up and up, and then government has to put a cap and say we can't.
I'm almost out of time, but if we let the government create a public plan and increase its subsidy year after year, I really have two questions. One, how will the private sector stay in competition with that if the government sector's subsidy goes up year after year? And second, if the government both offers a plan and also sets the rules for its plan and the private plan, aren't we allowing the government to be both a player in the game and a referee in the same game?
Right, and that was what I mentioned in my testimony. If you have guaranteed issue, community rating, and a lot of mandates, that is going to push up the cost of the plans. And if the government prices their plans slightly cheaper, you're going to crowd out the private insurers and leave us with a taxpayer-funded plan, which ultimately will be too expensive and end up with ration care. And it's not going to help the American people get the finest health care available.
You'd rather give them cash and let them make a choice?
Right, absolutely.
All right. Thank you. Gentlewoman from Illinois, Ms. Schakowsky.
Thank you. If I could just ask each of you, do you think that health care is a right?
Yes.
Ms. Feder?
No.
Healthcare is too big a label. Some kind of healthcare is absolutely a right, viewed in this country. It's not in the Constitution. However, think of someone lying in the street, a car hit them, they're bleeding. Does anyone in this room think you don't have a right to be picked up and brought to the nearest hospital? Does any American think that right does not exist? So yes, some healthcare, a lot of it is a right, and some of it, like plastic surgery, is not.
Well, that's not necessarily health care.
Cosmetic surgery.
Yeah, yeah.
And we do have, as someone mentioned earlier, EMTALA, I think it was Ubi, that we have EMTALA, which is a law that says no one can be denied access to an emergency room.
I know, I'm just asking if you think it's a right.
No,
you said
because how
you
do you
don't.
determine how open-ended that right is and what it will cost? And so I think that we're entitled to life, liberty, and the pursuit of happiness.
Yeah,
We need access.
I want,
access.
it's my time, and I reclaim it. What would you say, Ms. Pipes, though, that 87% of Canadians view the elimination of public health care as a negative? This is according to McGill professor Stuart Soroka, author of the study. It was the highest ranking opinion in the entire survey, that they would not want to eliminate their public health care system.
Well, there's poll numbers that have come out of Decima that the majority of Canadians, 47% versus 41%, are dissatisfied with the Canadian healthcare system.
Well, you spend about 10% of GDP, you said, on health care in Canada. What do we spend, Ms. Feder?
16% here.
Okay.
More than that?
But it's going up. It is going up, yes.
Yeah. So, in other words, perhaps if more were spent on the Canadian healthcare system, it could serve more people. But I'm not looking for a comment now. I'm concerned about this notion, and you referred to it earlier, Dr. Reinhardt, and I'd appreciate if you or Dr. Feder would want to comment on that. The United States, it seems to me, does in fact ration health care. That the dollar bill is essentially that ration card, and that when you have more than half of Americans who say that they haven't gotten health care, they have postponed or have completely eliminated health care that they need, that clearly this health care is being rationed, that people, we don't count the people not in line, because they can't afford it. And I wonder, I think this is really an important point about comparing our system with a Canadian system where they actually count people that wait in line, and either one of you or both.
Yeah, I appreciate the question, Congresswoman Schakowsky, and the first point I would make is, as you were making earlier, is that we are not talking about turning the American system into the Canadian system. We're talking about slowing the growth and making sure of healthcare costs and making sure everybody has affordable insurance and affordable care. And as Dr. Reinhardt said earlier, that when people can't afford care, when they don't have insurance coverage or there are holes in their insurance coverage, care is being rationed. And I find very interesting, not just people who aren't showing up because they know they can't afford it, but how much do you hear from your constituents about the runaround they get from their insurance companies, the denials, the submitting the claims over and over again, the not being able to get service?
All the time.
Exactly. So what is it? We think this system works. It's being compared to a straw man. What we need to do is to fix our system, get better value for the dollar, and make sure that everybody gets access to care when they need it.
And prescriptions left in the drawer because they can't afford to fill them.
We have the evidence of it.
It so happens I've written 3 papers on this rationing issue. One, in fact, entitled Styles of Rationing, Canada versus the U.S. And there is no question they do ration with a queue for some procedures up there. And there is no question we ration through price and ability to pay. And to deny that defies anything any freshman is ever taught if they have a good economics professor. I could show you textbook after textbook from people who are actually conservative politically who says the role of prices is to ration. And we use price as a rationing device. We also know it. There was a recent study out, Judy, you may know it, that showed for low-income people, they actually consume less health care because they very often are uninsured. But if we compare people who do not have insurance with those who have insurance, Jack Hadley's numbers, the uninsured get 43% of the care that similarly situated insured get. And to deny that that is rationing borders on the mischievous. I think that is rationing, and we are discussing styles of rationing. Canadians have a different view about what is equitable than what apparently we have.
Thank you. Bottom line, we want to do an American system that works for everyone. Thank you.
Thank you. Gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. And I did, by listening, appreciate a lot of the comments, and I'm not going to be long. Following up on John Shattuck's comments about buying power, just 2 quick questions. There is a debate for those who propose that about it being a mandatory or voluntary system. If you use the automobile insurance debate, if you drive in states, you have to have insurance. Right. I'm of the point of view that if you went to a private option of what's called the public choice, however we're going to define that, that it would be, everyone would have to cover, I mean, you would not have a choice to be out. Everyone would have to have something. You would also have to force then the insurers to have the wide breadth of everyone involved. I mean, you have to hold, you couldn't allow them to cherry pick is kind of the terminology I use. And it's a mandatory system. And the final thing is there would have to be, the basic package would have to be a catastrophic package. I mean, the cost shifting, what goes in a hospital, and what everybody's worried about is catastrophic care. And maybe you could allow people through health savings accounts or just their own dollars to do the preventative care, to go to the doctor for the cold and flu and all that other stuff. What do you think about that premise? And if you, Dr. Reinhardt, if you would just then mention it, and Ms. Pipes and Dr. Fetter, and that would be the only question. This is what's been bubbling around in my thought process. How do you get to the 44 million or 47 uninsured Americans? They have to have insurance. They have to have a catastrophic package. That's what what would you say to those comments?
Well, ultimately, when you discuss universal coverage and when do you know, how have you reached this fairly, the only metric that really makes sense to me would be to say, what fraction of a family's discretionary income after food, housing, and shelter should a family in America be required to contribute towards its own health care. And presumably that percentage would be small for a waitress or a cab driver, and it would be higher for a full professor at Princeton. You could easily ask me to contribute 10, 12% of our household budget towards health care, and you would not ask a waitress to do that. So that's the first thing. Now, with respect to the choice market for private insurance, if you put community rating on, say you must charge everyone the same, sick or healthy, and guaranteed issue, if you don't couple that with mandatory insurance, you will get the death spiral of private insurance, which we actually see in New Jersey happening. So those two go together. The alternative model would be that you say, okay, we let the private insurers medically underwrite. So if somebody is sick, they pay a huge premium. Somebody has AIDS, they pay $80,000 a year, and someone who's very healthy gets it very cheap. But then you would have to have a bureaucracy that could give subsidies to the chronically ill with the huge premiums that they're charged, and subsidize them to the tune that ultimately you're happy with that percentage. And this is really something, I think my colleague Mark Pauly at UPenn, and who's the co-author, had a very lovely paper on this. How do you know that you're equitable? And he says he proposes this metric. Adam Wagstaff at the World Bank had the same thing for the international scene.
Yes, sir. And I don't want to cut you off. I do want Ms. Pipes and Dr. Fetter briefly. I only have a minute left. If you could kind of summarize that quickly. Sorry, Dr. Reinhardt.
No, and you mentioned mandatory car insurance, but 15% of drivers in this country, even though all states but 2 have mandatory car insurance, are driving around without car insurance. And we've seen the experiment in Massachusetts, where now after, it'll be 3 years old in April, that still 2.5% of people are uninsured, and about 60% of the people signed up for the Commonwealth Care, the subsidized thing. So it's very hard to take the American mindset and ensure and make them do. I mean, Hillary Clinton said the only way you could enforce a mandate was to garnish wages. I don't think that's the American way. And so I think it's very hard. But if we have, universal choice and people can choose the system that best suits them, I think we will get a lot of those 45.7 million Americans going into the insurance market. There's nothing wrong with having a high-risk pool for people who are falling between the cracks.
Thank you, Dr. Fetter. With the chairman's permission.
Yeah, it's okay?
Yes, sure.
I'll be quick. I was interested in what you said about making rules for insurance, because as I listened to Mr. Shattuck, no matter how big that phone book gets of insurance companies, if 20% of the people account for 80% of the spending we spend on healthcare when we get sick, insurers always win if they insure us when we're healthy and avoid us when we're sick. So you've got to have rules. It's got to be group insurance. That's the only way it can work. I am less concerned about mandates than I am concerned about making sure that everybody has the wherewithal to buy insurance. So that means subsidies, making those adequate. And also, I think facilitating enrollment in many ways can get everybody into the system so that we fix it. Not only, people don't walk around with a U for uninsured on their foreheads. There's a problem in the whole system, and we need to make it work for everybody.
Thank you, Mr. Chairman.
Thank you. Mr. Gonzalez.
Thank you very much, Mr. Chairman. First, just a couple of observations. Trying to use the car insurance as an analogy is a terrible mistake, because if it operated like health care providers, what would happen is your first accident or speeding ticket, the insurer would drop you. Then you go to the next insurance company, and they'd say you had a pre-existing condition and wouldn't offer you any insurance. The other observation is anybody that doesn't believe that our health care system is broken would be those individuals that presently have coverage, number one, but even out of those, you'd have to say it'd be those that are healthy and haven't attempted to use the coverage.
Right.
I'm going to quote from a paper from 2004. I get these all the time from a physician friend of mine. Every time we have a hearing, he'll send me an email and refer me to articles. But I'm going to agree with this article, and I think it's going to embrace some of the concepts that have been advocated by members on the other side of the aisle here in the committee. And this is by Michael Porter and Elizabeth Olmsted Teesburg. We believe that competition is the root of the problem with U.S. healthcare performance. But this does not mean we advocate a state-controlled system or a single-payer system. Of course, what we have here is we're talking about a public option, which is separate, because those approaches would make things only worse. On the contrary, competition is also the solution. But the nature of the competition in healthcare must change. Our research shows that competition in the healthcare system occurs at the wrong level, over the wrong things, in the wrong geographic markets, and at the wrong time. Competition has actually been all but eliminated just where and when it is most important. The healthcare system can achieve stunning gains in quality and efficiency, and employers, the major purchasers of healthcare services, could lead the transformation. This paper was written in 2004. The jury was out, juries come in, employers have not been able to do it. Someone has suggested that a well-educated consumer will be able to do it as long as we give vouchers or some sort. And that we know that we don't have that level of competency out there, through no fault of the consumer, of course. I would like comments from Dr. Reinhardt and Dr. Fetter as to the way I view this, without trying to be married to any kind of ideology to the point of a faith or a religion that doesn't allow us to discuss this thing rationally and in good faith. I believe what we're espousing here, and hopefully we'll have a bill, which is going to be a public option, will be the vehicle that will allow us to bring into the marketplace those wonderful ideas of competition, consumer choice, education, quality, efficiency, and get us our biggest benefit out of every dollar. Is this what we see here today? That's what I really think we're discussing, because we're really talking about concept at this point, and we may bring into immigration and other things, but those are issues, and we'll have, for another day, we'll have those particular issues. But overall, conceptually speaking, is that what this will bring to this debate as far as a public option? Dr. Reinhardt.
Well, this paper was in a Harvard Business Review by them, and then followed by a huge tome that they wrote, and a number of us reviewed it in Health Affairs. My view is their vision is correct but very utopian, because somehow they pretend that you can slice all ill health into episodes that begin and end, and that you can get physicians and hospitals and convalescent centers to build little groups that specialize, little focus factories, as Reggie Hertzlinger calls them, that specialize in this, and then advertise their price for the whole bundle and have a quality rating. And they don't even say who would do that, who would rate the quality. So as a concept, it's good, and I think we're gingerly moving that way, but it'll take at least 20 years before you would have realized that. But it is true, a public health plan does have the advantage of being able to experiment with that just like a private plan. I would urge you to think, they always say Medicare wasn't an innovator. Who developed the DRGs? It was Medicare, copied now around the world. Who developed the resource-based relative value scale for physicians? It was Medicare, now copied by every private insurance plan. So I believe the vision they had is good, and competition is a good thing, and none of us are against competition. But in the meantime, we have American families in dire need. We cannot wait for utopia, and we have to make sure, one of the principles, the President said, American families should not go broke over health care. I think on either side of the
Dr. Reinhardt, I do want to give Dr. Fetter an opportunity. I only have a minute left. I apologize.
I would, I'm for affordability, to finish Dr. Reinhardt's sentence, but I would say that what we're talking about in terms of paying more effectively for medical care is what we're talking about. So whether it's episode-based or better rewards for primary care or refining what we do in the existing system where we're overpaying within some DRGs, we've got a lot of room for improvements. And what you've put forward is that a public health insurance option can be a leader, not only in payment reform, but also in managing chronic illness, in promoting prevention, and all. We focused so heavily on fees because that is, I think, another straw man. What we need to focus on is leadership and accountability to us as an option in the health insurance system.
Thank you. The gentlewoman from Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman, and I want to also thank the panelists this morning for, I think the discussion will hopefully guide us through the minefield that we face trying to get to universal coverage and hopefully help us to shape a bill that we can get passed here and in the Senate and signed by the President. My first question is to Dr. Reinhardt and to Dr. Fader. I have a little bit of discomfort around the public plan, which both of you support as well as many others, because help me understand, is this the same as Medicaid or different to Medicaid? Are you going to have Medicaid for the poor and a public health, would it be a public health plan for everybody else? Or wouldn't that be continuing the same kind of two-tiered system that we're trying to get away from? And shouldn't it just be one public plan that Medicaid patients would have paid for them and others paying according to their income? Or is that what you envision anyway?
Well, as a practical matter, you would probably have to go with a separate plan because Medicaid involves the states. And that system, to fuse that with a public plan, which I think would be ideal, would be very difficult because the states might object to that. And then there would be an issue of the fiscal transfers to make that possible.
Yeah, I would just say to think of a public health insurance plan not as Medicaid, but think of it as a publicly owned, publicly accountable insurance option that you would be able to choose alongside private insurance options, with everyone having a guaranteed standardized set of benefits. So they would compete on their ability to deliver care efficiently, couldn't discriminate based on health status. And I would distinguish that from the importance of retaining Medicaid. Medicaid is not only do we have statutory law that provides, or statutes that protect very low-income people that we should extend, I think, to all people below poverty, but there are a whole body of law defined through litigation that actually protects very low-income people, and that, I think, to disrupt that would be a mistake.
Yeah, it's not that I want to disrupt it, it's just that Medicaid has not been really providing the kind of outcomes that we want to see, but
Now,
we can fix that as well.
Your concern is well taken, and that gets to whether we're paying providers adequately to serve people. So we want to keep the protections, which is if we have it as a public health insurance plan among choices, it's not going to have as generous benefits as Medicaid has.
And Dr. Reinhardt, one of the people on the other panel, Professor Biker, I guess, spends a considerable part of her written testimony on the problem of the sick and the uninsured, which is a population group that I'm particularly concerned about. We, in the Tri-Caucus, spend a lot of our time and focus on eliminating health disparities in poor racial and ethnic minorities, rural individuals, and they would be sicker and prominently among the uninsured. And because they're sicker, bringing them into the system, Professor Biker would say, would drive up the cost of care. It drives up the cost of care now, affects the quality of care for the uninsured. So how do we ensure that their high costs, because we're bringing them in to make sure that they have access to care, how do we work the system so that it doesn't drive up, so that we keep insurance affordable and still provide that high level of service at the outset? Or should we just make the investment and not worry, know that it's going to pay off in the long run?
Well, I wouldn't say make the investment and not worry about it. I would say make the investment and then worry about a long-term strategy to take costs into our gun sights and really start looking at How much, for example, do we spend on administration that buys no health care that could be reduced? How much these Wenberg variations I talked about in Medicare, and you have them in the private sector as well. So I think cost control, we ought to be able to do this more cheaply than we are in America. Even the Business Roundtable says that. But you can't wait. These American families are hard-pressed. We're facing a deep recession. There'll be ever more of them. And to say, if there's somebody who is poor and sick, and now we serve them, and that'll drive up cost, I would say yes, it will. But that's why you're doing it.
And this is not to eliminate the need for focusing more on prevention or other programs to eliminate the health disparities. I know, well, it's part of the testimony in the other panel, and I wanted to get a response on that. Ms. Pipes, despite your data that shows that the Canadian system may not be working as well as many purported to be, how do you explain the 20 or 23% value gap? Our country is running 20 or 23% behind yours on the value we get for health care. How do you reconcile those two things?
Well, I think that, Canadians, a lot of Canadians come to the United States and get health care when they're on waiting lists. So I think it's very hard when the government runs a health care system to actually measure, what actual comparisons between a totally government-run system and a system that is a hybrid of a number of different types. So I think, I don't know where your number comes from, but I haven't analyzed that number, and I would be interested in it. But I will say that 250 Canadian doctors leave Canada every year to come and practice in the United States, not just for the money because they can make more money, but because they can practice the type of medicine that they're trained to practice. Because doctors in Canada are basically union members. I mean, Dr. Reinhardt mentioned that. When you work in a province, whether you work in British Columbia, your medical association negotiates your fee with the provincial government. My cousin's a corneal transplant specialist. He hasn't had an increase in 4 years because the government is in a deficit situation. And so doctors, it doesn't matter whether you're the best cardiac surgeon or the worst, everyone gets paid the same, and it destroys the incentive to attract the best people into healthcare and into medicine. And so, we want to continue to have, America has the best. People come from all over the world to get health care here, whether it's Silvio Berlusconi coming from Italy to get a pacemaker. We need to make some changes to build on the system we have and not break it down and have a public health plan that I think will crowd out the private insurers, because when you're adding tremendous costs with guaranteed issue, community rating, and these mandates. So I just think that universal choice will lead us to universal coverage, because young people, of the 17 million Americans earning over $50,000 a year, 2/3 of them are young people, and they don't need every single aspect. They want insurance to be insurance for catastrophes.
Well,
your time's over. Ms. Castor?
Thank you, Mr. Chairman, and thanks to the panel. I'd like to go back to what is driving these huge increases over the past decade in the cost of health care. And recall that health insurance premiums have outpaced wage growth. From 1999 to 2008, premiums grew at 3 times the rate of wages. And Dr. Reinhardt, in your testimony, you said that we've seen that just over the past 7 years, the average total outlay on health care for a family from all sources has nearly doubled. And folks back home, they want to know why. It's out of control. One easy answer has been when I go to the hospitals, that's an easy case, because they say, gosh, the uncompensated care, the folks that come into the ER that do not have health insurance and have chronic disease or something, that translates to them. They get that, and they say, they understand we're subsidized. If you have private insurance, they're subsidizing part of that uncompensated care. The hospitals in my area, in turn, have developed a clinic system with very low administrative costs. It's a partnership with the private doctors, private hospitals, and nonprofits, and it's saving everyone money. But what else is driving these astronomical increases, lessons that we can learn moving forward as we develop this public choice option?
Doctor.
Well, the American system is expensive because we have structured it to make the demand side weak and the supply side strong. And all the other nations that are cheaper have a strong demand side or a stronger demand side and a weaker supply side. And it's really how you apportion the market power. I mentioned that even in a large insurer like WellPoint had real trouble negotiating with the Sutter Health System in California because it's a big system. You cannot run a health insurance plan without having that in your network, and therefore they had all the market power. So I think it's quite clear. It's part of the reason why we have a very luxurious system, overstocked. You read MedPAC, we have too many MRI machines. Canada may have too few, but everyone agrees we have too many. It's because we essentially turned over a disproportionate amount of power to the supply side of the system.
Let me answer it a slightly different way. I think that your constituents will have had the experience of being bumped from doctor to doctor, having tests duplicated, finding it impossible to get, being stuck in a hospital, not able to get out, seeing attempts at treatment that seem to be not to work. What we have, what we're lacking, and what we're talking about with comparative effectiveness research, is to provide an information-based, real evidence, so that you don't go to what Uwe was talking about, the supply side. You don't go to the pharmaceutical companies to find out which medication you need. You have an actual evidence base that enables you to know, enables doctors and patients to decide together on what works and what doesn't. And we can refine our payment mechanisms so that we are actually able to encourage and reward the provision of services that work and the discouragement of services that don't. There is no mechanism for that now, and that we're talking about developing that not in a punitive way, not in an arbitrary way, in a way that enables physicians and patients to choose.
You know, let me ask you all this. I'm starting to hear much greater concern as folks realize the astronomical salaries in the corporate sector and healthcare, and the HMOs are not immune to this. And I wonder if you see any analogy in what's going on in the financial system to healthcare. This is again a segment where the government, the taxpayers, are subsidizing private HMOs, and CEOs are making a multi-million dollar. We're talking over 25 million, 50 million per year. Is this also a factor in high cost? Shouldn't some of this be plowed back into people's health and not paid out in these astronomical salaries?
Well, if you think of the former United CEO who had $1.6 billion, the bulk of that income actually came from stock options, which is taken away from shareholders and not customers. So one has to be somewhat careful of how that salary is composed. If 50 million were a salary booked into payroll expense and added to the premiums, then of course it would be driving health care costs. But if it comes out of stock options, then it's another story. And he got 1.6 billion simply because during his reign the stock went up and up. What is much more troublesome to me with private insurance is that as an industry, I think they have not done enough to reduce the administrative cost of healthcare, that the amount of money they need to run the business is higher than I think it would be if they were all electronic, had a common nomenclature, common claims form, etc. The president of Johns Hopkins mentioned in a speech not long ago, he deals with 700 distinct managed care contracts, each with different terms and so on. If you were to look at a Canadian, there was just a program. They were looking at a Canadian hospital and American hospitals in terms of the billing clerks. You would be shocked at the difference. That's where the real money is, not so much CEO salaries.
Well, also, I think that Dr. Ben Zeiker of the Pacific Research Institute did a study comparing administrative costs of government programs versus the private sector. And there are a lot of things that aren't included in the government Medicare and Medicaid. So I think you should take a look at that study.
Well, that's interesting because the example of my local community that is a collaboration of the hospitals and doctors and our county government, our administrative costs are way low, and that's been proven out for a number of years.
I urge you to look.
We're going to have to end on this one. Sorry. Mr. Braley from Iowa.
Thank you, Mr. Chairman. Ms. Pipes, you have certainly been a prolific commentator on healthcare issues. Do you hold yourself out at this hearing as a healthcare policy expert?
Yes, I'm an economist by training, grew up in Vancouver, went to college there, and was an economist at the Fraser Institute in Vancouver, and then came to the U.S. in '91.
One of the things that's been difficult for me to do is ascertain the extent of your educational background. Do you have any advanced degrees in economics?
I have an honors degree in economics from the University of British Columbia, and then I joined the Fraser Institute working under Dr. Michael Walker, and started out as an econometrician. I won the Canadian Crystal Ball Award.
So the answer to my question would be no, correct?
No, I have an honors BA in economics, but have worked in the economic research field for.
And you don't have a master's or PhD in healthcare policy?
No, I don't.
Or in public policy as a general concept?
No, but I've worked in the field.
All right. On the website for the Pacific Research Institute, you are identified in your individual bio as a scholar. Are you aware of that?
Yes, I am a scholar. I write a lot on healthcare. I write books.
Have you published any scholarly treatises in a peer-reviewed journal of economics on healthcare policy?
Yes.
And can you give us some examples?
I've done some things in health affairs. Over the past, and in Canada.
But can you just identify the scholarly journal that's a peer-reviewed journal of economics?
Right. Well, health affairs is, I think, I don't know whether you would say it is, but
it's peer-reviewed.
Yes.
All right. And do you have a CV or resume that you use for your official purposes?
Well, I use what we have on our website. I don't. I mean, I have one in my desk from when I got my job in 1991. I don't keep it up to date, but I could.
I mean, do you have a listing of your publications, a listing of your appearances? Some people do this as a way to let people that they're speaking before know what the content of their background and expertise is. Do you have such a listing that you could provide to the committee?
You'll see that I write for the Wall Street Journal and the.
Just please answer my question. I don't have much time.
Sorry.
Could you provide that to the committee?
Course. Yes.
Okay.
Or you can.
Now, one of the things you asked about, or you raised in the conclusion of your opening remarks, was the need for medical malpractice reform. Do you remember that?
Yes.
I'm sure you're aware that the Institutes of Medicine has done a series of 3 important studies dealing with the issue of preventable medical errors and the cost that they contribute to the overall healthcare economy of this country. The seminal work was the first work in 2000, To Err is Human, and in that report, the Institutes of Medicine concluded that preventable adverse events are a leading cause of death in the United States. The results of the studies imply that at least 44,000 and perhaps as many as 98,000 Americans die in hospitals each year as a result of medical errors. Deaths due to preventable adverse events exceeds the death attributable to motor vehicle accidents, breast cancer, or AIDS. That was then followed by another seminal study, Patient Safety, also from the IOM. And in that study, they included the finding that the committee strongly believes that patient safety is indistinguishable from the delivery of quality care. A new delivery system must be built to achieve substantial improvement in patient safety, a system that is capable of preventing errors from occurring in the first place, while at the same time incorporating lessons learned from any errors that do occur. And then we had the important 2006 study from the Institutes of Medicine, Preventing Medication Errors, which concluded that medication errors are surprisingly common and costly to the nation. The committee concludes there are at least 1.5 million preventable adverse drug events that occur in the United States each year. The true number may be much higher, and they issued a conservative estimate that these adverse drug events cost our economy at minimum $3.5 billion a year. So what I'm wondering is why, when we talk about reforming our healthcare system, don't people who come from your point of view come to this committee and talk about constructive ways we're going to reduce preventable medical errors, which we all know are the most dramatic way that we can reduce the cost of medical malpractice in this country?
Well, I think you should look at some of the work done by Dr. Betsy McCoy, who has done work on infectious diseases and shows that more people die in hospitals from infectious diseases by a major part compared to medical errors. So I think that's important.
Let's talk about that, though, because are you familiar with the Joint Commission on Accreditation of Healthcare Associations, and are you familiar with their Sentinel Event Program?
Right.
Do you know that in the first 10 years the Sentinel Event Program was in place over a 10-year period? Only 3,000 Sentinel event reports were filed with JCAHO, which is astonishing considering the incidence of preventable medical errors that resulted in deaths only, not serious injuries, when those numbers would suggest that they should have been receiving 44,000 to 98,000 reports at a minimum. So isn't it clear that the system of accountability that we currently use is completely failing American health consumers and making a more safe system?
Well, I think all doctors are interested in people living longer and healthier lives. And as I say, more people are dying from infectious diseases in hospitals than from medical errors. Unfortunately.
Well, I would disagree with that characterization because most people would tell you who study this issue that one of the most preventable forms of an adverse event in a hospital setting is nosocomial infection. And in fact, there's been a lot of research that indicates that despite overwhelming evidence from medical economists, hospitals are reluctant to move to a business model that will allow them to reduce the incidence of nosocomial infections. So I disagree with your characterization that a nosocomial infection is not a preventable medical error.
No,
I'm going to let you
agree that you're
Ms.
right.
Pipes, I'm sorry. I'd like you to respond, and then we have to end because we're over a minute.
Right. No, I agree with you. We want to get infectious diseases in hospitals down because they are a tremendous problem and hardship. And on the medical malpractice reform, when they capped the non-economic damage awards in Texas at $250,000, a lot of docs who had left, OBGYNs and neurosurgeons, are now coming back into Texas because there's an environment there where doctors want to practice medicine. We've seen in states like Pennsylvania and Nevada where a lot of OBGYNs and neurosurgeons have left the practice of medicine because the cost of their med mal is so expensive that it's not profitable for them to practice medicine.
Thank you. Next is Ms. Baldwin.
Thank you, Mr. Chairman. Professor Reinhardt, I enjoyed some of the points made in the end of your written testimony that you weren't able to make in your more abbreviated oral testimony. One of the things that I'm interested in is the role. Well, first, your comment, you call it the electronic farmer's market. I think we're used to calling it the exchange or connector, but that entity would have to be empowered with regulatory powers to supervise and enforce the reputability of the products being offered. We've also had a lot of comments about having the inclusion of a public option. And in fact, Dr. Fader said a public system, I think I'm quoting accurately, a public system can keep the private system honest. So I'd like to hear your take on the interplay between the regulatory powers that are going to be necessary and having a public sector option perhaps substituting for that or at least enhancing it.
Well, if you want to have any market, no matter what it is, has to be regulated. And we now find out, to our great dismay, that the market for credit default swaps also should have been regulated. So you need that. And in healthcare, with the insurance industry, it's still the Wild West in many ways when you come to the individual market. That's not true for the employment-based system. So you do need to be sure that these policies don't have fine print that ultimately leave you uninsured rather than insured. So you need regulation there. You then have to make a decision if you want community rating or not. If you say we allow medical underwriting, then the subsidies you give people have to be tailored to their health status, which is difficult to do. So I think such a body would by nature have to be regulatory, endowed with the power to regulate, or it goes back to government.
Dr. Fader, you address as, I think, your fourth point that you gave us take-home points that we have to stop discriminating against sick people in coverage. I want to hear your take on whether the high-risk pools that have been available as a tool to cover sicker populations, have they been a success story, a failure, somewhere in between? What's your take on that?
Congresswoman Baldwin, my colleague Karen Pollis will be testifying on the next panel, and I will be drawing insufficiently on her expertise in answering the question. But I think high-risk pools are problematic. One, they pull off people from the rest of the system, and I think we would be better pooling risk everybody together. Second, they have been completely inadequately funded, charge the people who are high risk high rates so that many people who are sick can't get into the high-risk pool. Third, as I understand it, they impose pre-existing condition exclusions on people who are sick or high risk, which I'm laughing because that boggles the mind. So it is possibly true that adequately funded with good rules, it may all come together, and I urge you to ask Karen to tell you that, but as it has been treated, it is not a substitute for a well-regulated insurance market that everybody gets to choose a plan, regardless of health status.
And some states, the high-risk pools work better than in others, depending on funding.
Mr. Chairman, I yield back the remainder time.
Thank you. The gentleman from Connecticut, Mr. Murphy.
Thank you very much, Mr. Chairman. Ms. Pipes, I want to go back to this issue of wait times for a moment. I think we spend a little bit too much time obsessing over one system, the Canadian system, given the number of other examples. But one of the statistics that's often used is wait times for specific surgeries like hip replacements and knee replacements. And there certainly are longer waiting times in Canada for those procedures. For knee replacements, I think it's about 3 weeks in Canada, about 8 weeks in Canada, about 3 weeks in the United States. But what gets lost is that the payer for those surgeries in the United States is the government. Most often, 71, 70 years old is the average age for a knee replacement surgery. And in the United States, Medicare seems to do a pretty decent job at moving those people through the system and getting care at a more expedient rate than Canada does. And so I guess it's a way of asking this question. You sort of, in your remarks, seem to suggest that just an inherent flaw of a government system is longer wait times. But it seems that our experience with Medicare is that if you put the money behind the program, that if you make the choice to get people care faster, then a public system or a public plan could work just as well as a private plan could. So do you think that it's inherent in a public versus private dichotomy, or do you think that if you choose to spend the money and get the provider network and get the wait times down, that you could get wait times down in a public plan?
Well, in Canada, you could reduce the waiting times by putting more and more taxpayer dollars into the healthcare system. The problem is that Canadians are taxed at a much higher rate than Americans, and the government feels that where they are now, they're taxed enough. And, you know, I did work at the Fraser Institute in my early years called Tax Facts, where we developed the Canadian Consumer Tax Index and compared the levels of tax in Canada versus the United States. And we work on average 2 months longer because we have a lot more government in our lives in Canada. So, you know, in the case of my mother, who needed a knee replacement, and she was a senior, she waited 2 years to get a knee replacement. Then when they replaced it with a plastic knee because they said their actuarial records showed that at her age, she would only live for 5 years, and therefore the plastic knee was more efficient and more cost-effective. But, you know, she lived 8 years longer, and she was in severe pain. So, you know, this is how Canada, you know, controls costs, and people don't have access to Pap smears on a regular basis or PSA tests and things. We have a lot of prevention in this country, but these things are more expensive. But we have to decide in this country, you know, if you want a lot more government in your health care, you're probably going to end up rationing care because, as we've seen in Massachusetts, the costs have been a lot more than what the original estimates were.
I think we both use anecdotes on both sides of this debate, but I would say that your testimony has been peppered with stories about Canadian healthcare experience, and I'm just looking at the data on knee replacement surgeries that just don't back up that type of time frame. And I do agree with you that it's a matter of choosing to invest in the system. I mean, no one's talking about a United States healthcare reform proposal ratcheting down the percentage of GDP to what Canada spends today. We would love to control costs, but we're not going to spend as much as Canada does, and we're going to hopefully get a little bit more than they do. And which brings me to a question for Dr. Reinhardt. In your testimony, one of the things you talked about was the relative ineffectiveness of the private insurance system to get a handle on the cost of care in this country. And that's been a vexing question for me for years. With the private sector healthcare system has obviously immediate incentives to bring down the cost of care because it increases value for the company, for its shareholders, and doesn't have the burden that some government systems does of having to go through a regulatory process to try to change behavior. And yet, we don't have private insurers investing in simple preventative procedures and costs that could bring down care. Why do you think that our private healthcare insurance system in this country isn't doing as good a job as it could controlling costs and investing in prevention?
I think that's an extremely interesting question because in the 80s, a lot of us, myself, thought the HMOs actually could do exactly what you said. And there were proposals to make Medicare into a defined contribution plan because there was talk that an HMO, well-run private plan, could do the same thing Medicare does, much cheaper. Sometimes even people said 25%. So then we gave them 95% of the average actuarial per capita cost and said that's very generous. They should be able to shoot fish in a barrel, given Medicare is so inefficient, as everyone said. But they couldn't. As you know, in the 90s, they all pulled out. And the only way they seem to have made it work is to get that 14% extra. I find that very disappointing as an economist, that the private market that I usually believe in somehow failed us here. Why are they not more efficient? Why, for example, given Florida is a lot more expensive for Medicare than, say, Iowa would be, why wouldn't HMOs thrive in Florida managing care? I don't think they have proven yet that they can do it. I hope someday they can, but so far they have not. And it's a very intriguing question why they have not been able to reduce costs. And in the early decade, you know, premiums went up 14, 15%. And I always said, this is stunning. Medicare has nothing like these increases, and yet the private sector came with these increases.
We have to move on.
Thank you, Mr. Chairman.
Sure. Gentleman from New York, Mr. Wiener.
Thank you, Mr. Chairman. I think to some degree this discussion about public versus private plans, I think might be too, it's too binary a way to look at it. What does Congress have? I mean, it has a private plan, right? But we aggregate our many employees. We offer a phone book not dissimilar to the size of Mr. Shadeg's visual aid there, of different options, of different prices, of different types of service. What does the panel think Congress has in the language of this discussion?
You can argue that what Congress has is an example of a connector in the Federal Employees Health Benefit Plan. And for purposes of disclosure, I'm the wife of a federal retiree, so I have it too. And we choose from those of us who have it from a set of private health insurance plans. So what is being talked about when we talk is talking about adding a public health insurance plan to that menu.
And Ms. Pipes, would you two characterize what Congress has as a private model in the way you've described it?
Well, the Federal Employees Health Benefit Plan, of course, is part of the government, but they have private plans within that. And my understanding is that the Blue Cross sort of traditional plan still costs members of Congress about $400 a month. Because I think the plan is about $1,200 a month, and it's
Right, but mightn't there, forgive me for interrupting, but mightn't there be, I mean, look, I think we have a political imperative, and as we try to work this out, is to try to take that large percentage of American citizens who have health insurance that they're satisfied with, that would like to pay less, but keep them invested in this discussion. It's important that they be involved. But I also think that this notion that government involvement, the moment it touches this, creates a problem, and letting everyone go out and deal with this problem on their own, as Mr. Shadegg and you have suggested, goes too far in the other extreme. For example, what if you aggregated a whole bunch of businesses that were on their own not able to shop very competitively for health insurance plans, but you as the government, we as the government said, you know what, we're going to take 100,000 employees of small businesses in New York City, and we're going to go out and we're going to put a book together of different insurance plans who now, knowing they're getting 100,000 customers. And we're also going to do a couple of other things. We're going to say you can't consider you can't exclude people because they have pre-existing conditions. There are certain minimum standards that you need to have and the like. You're then kind of taking a little bit of the private model, a little bit of the public model, a little from column A and column B. Would you find that offensive to your notion that the government should not be involved in this?
Well, I was a very big supporter of association health plans. Association health plans, which would have allowed under a lot of smaller businesses to group together and then go into the market and negotiate better rates. So I'm a big fan of small business needs.
So you'd be fine with government putting its finger on the scale, having standards, having regulations, requiring certain coverage and the like, so long as the people writing the checks to the doctors were private insurance companies rather than the government.
Right, and I think we've seen, New York has community rating guaranteed issue. You have one, New York and New Jersey have some of the most expensive insurance plans because of those. I would prefer to see some of the mandates and things like that removed. I mean, if you want to get a plan that has community rating
I
guaranteed
understand.
issue,
I just have a moment more. Dr. Reinhardt, can I ask you a question that touched on what Mr. Murphy concluded with? Do you think that insurance companies in the present model intentionally do things to make money on the float? Do you think the reason there are 6 major insurance companies and they have 6 different forms, for example, is an example of them trying to build in inefficiencies that benefit their bottom line but make reimbursement slower, make it more difficult for doctors, more difficult for patients to navigate? Do you think they're trying to find ways? I mean, are they not incentivized by a different set of imperatives than perhaps Medicaid is? Maybe that's why the inefficiencies remain. I mean, you go into a hospital administrator's office and you see literally inboxes and outboxes for all the different insurance companies because, despite the fact they're asking for the same information, they intentionally keep that inefficiency in the system because they make money on it.
Well, I think if interest rates, short-term rates were 8–9%, I think you have a point there. In fact, I teach a course in financial management, and that was one of my lecture notes, how much you could make off the float by just dragging out payment. But with low interest rates such as we've had, I think it would be unprofitable.
No, I was thinking more of the structure, the way the industry has structured itself to have these inefficiencies, not just for the moment. Do you think that's why it evolved to be so inefficient and slow lumbering very often is because they make money on that? When you were giving that class in 2003 or 4, what were you, or 2000, well, maybe that's too early, 2005, what were you saying?
Well, I mean, there was definitely, I took a health plan in New York and showed that basically they made most of their money on the float, which is, of course, not necessarily dishonest. That is part of an insurance industry's source of income, is to make money on the float. What was questionable is, did they deliberately drag out payment so that they could make more money on the float? And that's easily fixed by saying, if you don't pay within 30 days, you'll pay an interest rate. Just like in any trade credit in business, you could say, you pay within 30 days, that's fine. If you drag it out longer, you have to pay the hospital 1% per month. You drag it out. That would solve the problem, which is, in fact, what my class and I concluded could be done.
Thank you, Mr. Chairman.
Thank you. Chairman Waxman.
Thank you very much, Mr. Chairman. I've been listening to the discussion. I had to miss some of the earlier presentations, but I think this has been an excellent panel. Dr. Reinhardt, you've indicated you think that whatever we do, employer-sponsored insurance is shrinking, and it will continue to shrink, and that this may be a good time for us to develop an alternative for people, an alternative based on a reformed individual market, a public insurance program, or both. And that's been the basis of a lot of the discussion and debate. But I want to ask you, what should a health reform bill do to make sure that health care coverage is affordable for those who no longer have access to employer-sponsored coverage? Should we look at the amount of money that people pay out of their income for health? Should we try to say that you not just look at the premium, but all the out-of-pocket costs, and then say that people shouldn't have to pay more than 10%, 7% less or more of their income?
I think, Chairman Waxman, that would be the way to go. You have to focus on total health spending, not just premium, and then relate it to the ability of the family to pay for that. And that, in some way, is an ethical, political decision where you put those numbers. If you were to say somebody making less than $25,000, what should that percentage be? I personally feel 5% would stretch them already. While, if, as I said earlier, if it were someone like me, if you set that at 12%, I wouldn't cheer, but I think I could eat it, I could manage that, and it would be fine. And in the short run, bringing more people under insurance will cost money because they're not now, they're consuming less than half what insured people get. So we would have to top it off. And the estimates are somewhere 120 billion to 150 billion a year if you wanted really full coverage. But in the longer run, I do believe we can make healthcare in America a lot cheaper by doing the kind of cost containment candidates from both sides of the aisle had. Senator McCain also had ideas about cost containment, but they take longer to do.
Would you put a limit on the out-of-pocket expenses at, let's say, for low-income people, 5% of income? Would that make sense, given the cost of food, rent, and transportation? Would you try to figure out some kind of limit for those who have insurance and how much they'll have to pay out of their pockets?
I would absolutely try to figure out a limit. Now I'm shooting off the hip. I said 5% might even stretch people. I always wonder, as someone on the upper strata of the income distribution, I wonder how people on 25,000 family income make it. I used to be there. I grew up poor, but I forgot. So I think it's quite conceivable that 3% would stretch them. One would really have to budget this out, and that may be a good research project for Judy Fader to figure out. That's what you do.
Why, thank you.
Right.
In our spare time.
Whatever, I mean, obviously, you can list what families need to spend on basics.
What is Ms. Pipes, what do you think about that? Do you think there ought to be some limit on how much people have to pay for their health care?
Well, we have, people at 25,000 are obviously on Medicaid, and we have now an expanded state children's health insurance plan. So we've got a lot of government. I would like to see, as I've said, open up the market and, change the employer-based system. Allow it to still be there, but if you tax the employer benefits and then provide a refundable tax credit for those for those people, and also then I think we would see the individual market expand, and we'd see new competition, new insurers, and we would.
Well, let's say we don't get what we want, and people still, to get an adequate insurance coverage for their health needs, have to pay so much out of pocket. Should we assume that they just made a deal that didn't work out for them and let it go?
Well, if you look at Massachusetts, which had the individual employer mandate in their Romney Care plan in 2006, I mean, even after, the Commonwealth Care and the subsidized and free plans, you still saw that 20% of the people in the first year that should have bought insurance were excluded because the premiums were still too expensive. So it's very difficult for me. I don't know what the ideal number is, but
With the few seconds I have, I did want to ask you one other question.
Yes.
What would you think of the idea, and Mr. Weiner was sort of hinting at this, that people go to a connector and buy a private insurance policy, but the connector be like the federal employees benefit package, where you have, in effect, a lot of private choices that are group plans, so you eliminate the discrimination and all of that. What would you think of that kind of a connector to private plans?
Well, I would support
private insurance plans.
Yes, I would support a connector if it was totally private. But when you have government politicians or government bureaucrats determining, what has to be on the insurance plan in the connector, then often I see price going up, and it becomes more difficult. So I would support a totally private connector, but I'm not in support of a national insurance exchange such as Mr. President Obama has been talking about, because I see the controls that would be set by government causing
So you don't see that
insurance
working.
to go up.
Dr. Fader, if we had that ability for people to go to a connector and buy a private insurance plan, do you think it could work like the federal employees, and do you think you need a public option to provide some tension to keep the private insurance plans affordable and all of that?
I think the combination is ideal. I think what we're looking for is we can think of it as a public choice plan, essentially we create a place, as you say, where people are able to buy a group insurance without discrimination based on health status. But to do that alone without a public health insurance option, we have not seen great competition, whether in the federal employees health plan or any other. So that having the public health insurance option, as I said earlier, can make the whole market work more effectively, because we can hold it accountable for delivering good benefits, delivering good care, and essentially working to negotiate good rates with providers.
Thank you. Thank you, Mr. Chairman.
Thank you, Chairman Waxman. And I think all of our members have asked questions, so I really want to thank you. This was a great panel. It was really thought-provoking in terms of our efforts to draft legislation and address the whole issue of health care reform. So thank you very much. We appreciate it.
Thank you.
Thank you.
And I would ask the next panel to come forward.
I'm exhausted.
96 cents. What? That's the current price of an AIG share. 96 cents. It's up 14 cents today.
Time to buy. Average down.
We already own it. Who does? The taxpayer.
Keep going.
Who do you want where?
She's showing us.
Where do you want us?
Is this the right order, or?
Oops, sorry, Kate. Sorry. Would you like some water? You want some water? That's used. I'll give you a new one.
Thank you all for being here, and let me introduce each of you, starting on the left, and I hope I get the names right. First is it Mila Kaufman? Mila Kaufman, who is Superintendent of Insurance for the State of Maine Bureau of Insurance. Then we have Dr. John Kingsdale, who's Executive Director of the Commonwealth Health Insurance Connector Authority. And then we have Karen Politz, with 2 L's, not 3. Your name tag has 3 L's. Karen Politz, who is Research Professor at Georgetown University Health Policy Institute. And then we have Dr. Catherine Baker, who is Professor of Health Economics at the Harvard School of Public Health. And finally, Edmund Heiselmeyer? Heiselmeyer, who is a Senior Research Fellow at the Center for Health Policy Studies with the Heritage Foundation. Thank you all for being here. I know some of you have actually been here since the beginning, which has I'm sure been difficult, but In any case, we'll have statements from each of you, about 5 minutes each, starting with Ms. Kaufman.
Good afternoon, Mr. Chairman. I thank you and the committee for your leadership and willingness to address the healthcare crisis in America. It is both an honor and a privilege to be here before you to testify on this matter. I did submit a written statement, and I ask that the full written statement be admitted as part of the record.
And that will be the case for each of you. We'll enter your full written statement into the record.
Thank you. My name is Mila Kaufman. I'm the Superintendent of Insurance in Maine. My agency serves and protects the public through regulation and oversight of the insurance industry. It is my job to ensure that insurance companies keep their promises. My views about reforms and the private market have also been informed by my experience as a federal regulator and through my research on private health insurance as an associate professor at Georgetown. I believe it would be optimal for us to address the healthcare crisis in America in its entirety and for the federal government to ensure that all Americans have access to affordable, adequate, and secure health coverage. We live in the wealthiest nation in the world, yet we allow 18,000 Americans to die preventable deaths each year on our soil, not overseas, but here. The uninsured problem is estimated to cost our economy as much as $130 billion annually. Maine has been at the forefront of reforms, developing innovative initiatives to help finance medical care. Governor Baldacci has been a leader in establishing meaningful new health coverage options for individuals and small businesses, coverage that actually works for people when they are sick. Today, I will discuss the types of problems I'm not seeing because of the insurance reforms we have in Maine. First, it is important to remember that the private market is not a free market where purchasers have meaningful options. A free market assumes that everyone who wants to buy a product can choose among sellers competing for their business. Insurance companies do not compete to insure sick people. Insurance companies do not compete to insure sick people. An insurance company's success depends on its ability to minimize its risk. This provides incentives to cherry-pick healthy people and limit the number of unhealthy. It creates a private market from which many Americans are shut out. Even minor conditions like an allergy could be the basis for not selling you a policy. Also, in most states, insurers are allowed to charge higher rates for people with medical needs. This includes charging small businesses with sicker workers higher rates than small businesses with healthy workers. Maine is one of 5 states, in addition to New Jersey, Massachusetts, New York, and Vermont, that prohibits discrimination against individuals. We do this through guaranteed issue and adjusted community rating laws. Guarantee issue laws prohibit insurers from turning you down because of your health. Adjusted community rating laws prohibit insurers from charging sicker people higher rates. In addition to allowing people with medical needs to access private coverage, the combination of guaranteed issue and adjusted community rating laws has protected Maine consumers from some of the problems experienced by consumers and small businesses in other states. For example, we do not have rescissions, the problem that Chairman Waxman examined extensively as chairman of the Oversight Committee last year. This is a problem of having your policy retroactively canceled and being responsible for all the claims paid while you had the policy. Rescissions leave people on the hook for their medical bills and uninsurable, completely shut out of the private market. In Maine, a consumer does not fear losing his or her insurance because he or she may have completed the application for insurance incorrectly by mistake. In other states, consumers reported having their policies canceled retroactively for forgetting to report seeing a marriage counselor years before. In Maine, because insurers are not allowed to consider current or past medical needs in the first place when selling or pricing a policy, we have not had a problem with rescissions. We do have a problem, however, with affordability. The healthcare crisis is like a slow disease slowly killing off the middle class. It is a huge burden on employers of all sizes, on workers and families. Health insurance premiums are expensive because medical care is expensive. The private healthcare financing system has not effectively switched its focus and incentives from paying for sick care to promoting wellness. The current system rewards inefficiency. Carriers have not been able to negotiate effectively enough with providers to keep costs contained. Many factors contribute to the price of coverage. That includes the cost of medical care, administrative costs, and profits. Since 2002, our state's largest insurer has declared nearly $152 million in dividends. As far as next steps, there is a strong and appropriate role for federal policymakers. Americans need and demand meaningful health insurance coverage options to access and pay for necessary and, in many cases, life-saving medical care and services. Working together, the federal government and the states, we can address the health care crisis facing our nation's employers, workers, and families. I encourage you to build upon the foundation that you established in 1996 through HIPAA, a federal floor of protections, recognizing that states have and should be allowed to create and enforce higher levels of consumer protections as their populations need. In addition to improving and having strong protections, it is equally important to have strong regulators to enforce the law. State regulators have a long history of effectively protecting insurance consumers. I encourage you not to duplicate or replace the existing effective state-based insurance oversight system. Thank you, and I look forward to assisting you as you move forward in addressing the health care crisis.
Thank you. Dr. Kinsdale.
Thank you, Mr. Chairman, and members of the committee for this opportunity, and more importantly, for tackling this tough subject. I'm Executive Director of the Commonwealth Health Insurance Connector Authority, which is one of the principal agencies of health reform in Massachusetts, and I want to share with you a couple lessons learned. First of all, I would note we do have 97.4% of our residents covered with insurance. Before I heard that characterized in the former panel, I actually thought that was good. It is by far the highest insurance level in the United States, which sadly is below 85% nationally and declining as we speak. 2 years ago, after beginning implementation, we reached the principal goal of Massachusetts Chapter 58 of the Acts of 2006, near universal coverage. As a result, financial barriers to obtaining care have fallen markedly. An Urban Institute survey conducted midway through implementation, and I emphasize midway, found that in Massachusetts, rates of deferring needed care because of financial barriers were between 1/2 and 1/3 of the national average, and I think it's reasonable to assume as enrollment continued to grow, the financial barriers continued to fall. Importantly, Massachusetts has been able to achieve near universal coverage without a surge in medical inflation. In Commonwealth Care, a program run by the Health Connector for lower-income adults without access to employer-sponsored or other public coverages, annual premium increases average under 5%, and that's better than the national experience, in fact, most private experience in Massachusetts. Last week, we actually completed a bidding and plan selection for the next fiscal year, starting this July, which has produced the following rather extraordinary results. Choice of health plans and access to new primary care physicians will increase both the government spending per enrollee and what our 165,000 enrollees contribute monthly will decrease. And I've been in the insurance business for 35 years, and I don't usually use premium and decrease in the same sentence. The Connector runs actually two distinct programs. So its second program, Commonwealth Choice, unsubsidized enrollees enjoy a broad array of commercial health plans. They can compare 37 private options that we offer, confident that these plans have received the Commonwealth seal of approval for quality and value. On the day we initiated Commonwealth Choice and the individual mandate, July 1, 2007, purchasers of non-group plans experienced a huge gain. Their choice of plans increased suddenly, Their average premiums dropped markedly, and shopping for a plan became far easier. The result has been a resuscitation of the non-group market in Massachusetts. Prior to reform, non-group enrollment had been falling and premiums rising. A year later, the number of Massachusetts residents buying insurance directly on their own had doubled, and the premiums for standard coverage in the largest non-group plans had declined by 25%. Although we only offer 37 of the 180 options now available to individuals in Massachusetts, and they're priced the same in the connector or if purchased outside the connector, our growth has accounted for 50% of the doubling, 50% of the growth in non-group coverage in Massachusetts. Healthcare reform in the state is a shared responsibility. 1/3 of some 440,000 newly insured residents in the Commonwealth are in employer-sponsored plans, 1/3 in employer-sponsored plans. Near universal coverage is the product of shared responsibility among employers, taxpayers, and those directly involved in providing and reimbursing care. Our governor and our legislative leaders are committed to maintaining coverage and sustaining access. Now, let me just say a couple things about the two connector programs that I briefly described. The connector organizes a market to provide meaningful choice. Like any retailer, we ask our customers what they want. What they tell us is they want quality, meaning insurance options they can trust. They want value, meaning that we compare and showcase those plans which offer the best benefits for prices charged, and they want to be able to compare and shop online as opposed to calling each carrier, asking a bunch of questions, being put on hold, and then trying to compare notes at the end of the day. In both Commonwealth Care and Choice, we set standards for covered benefits. We rigorously evaluate the products before offering them, and we organize the choice of plans so that members can readily compare them. At enrollment and afterwards, we work with members and health plans to resolve member issues. With Commonwealth Care, since we are spending public monies for coverage, the connector specifies a set of benefits and conducts a highly competitive bidding process. But enrollees choose the plan. They choose the provider network. And if they choose a more expensive plan and they earn above 100% of FPL, they pay the additional costs. With Commonwealth Choice, which is the unsubsidized plan, our members are making a major buying decision. They're spending somewhere between $1,500 and $15,000 a year on insurance, depending on family size, age, zip code, et cetera, and the plan they choose. The connector sets 4 very different levels of benefits from which customers can choose and offers at least 6 different carriers on each of these benefit tiers. Our customers can shop by entering 3 pieces of information: age, household size, and zip code. We do offer customer telephone service, but 80% of the buying is online, typically in 20 to 30 minutes, to spend somewhere between $1,500 and $15,000 a year. And whichever plan they buy, enrollment is guaranteed, as is the next year's renewal, regardless of any change in members' medical condition. And believe it or not, after spending all that money, our members consistently thank us, even though we all know this is outrageously expensive. Frankly, this is, and I've been in the insurance business for over 30 years, the most consumer-friendly, consumer-driven offering that I've encountered. Thank you for your time and interest, and I'll be happy to do my best to answer questions.
Thank you. Ms. Politz, with 2 L's, not 3.
Like Mr. Pallone. Thank you, Mr. Chairman, members of the subcommittee. Health reform presents you with an opportunity to provide for more organized health insurance markets. Through a connector, as Dr. Kingsdale discussed, or an exchange, you can organize markets around explicit outcomes that you want to achieve from health insurance. I would like to briefly review 5 key goals. The first is to promote risk spreading and stability in health insurance. We've already talked today about how a small minority of people accounts for most healthcare spending, and this creates an overwhelming financial incentive for insurance companies to avoid risk. So we need rules to make that stop. I've testified before about medical underwriting practices that make it harder for consumers to get coverage, but other marketing practices make it difficult for consumers to keep affordable coverage. Age rating raises your premium steadily, and when you reach your 50s and 60s, when the incidence of most health conditions starts to increase, health insurance becomes very unaffordable. Carriers also use durational ratings to actually apply a surcharge to premiums based on how long you've held your policy. The idea is to encourage people who can still pass underwriting to not renew, but to go out and buy a new policy, go through underwriting again to get the good rate. But the people who can't do that get stranded in policies and see their premiums spiral. Health reform can help by changing the rules of health insurance marketplaces, require guarantee issue, community rating, no pre-act, so that we stop competition on the basis of risk avoidance. The second goal must be to assure adequate coverage. Today, we have 57 million Americans struggling with medical debt, and 3/4 of them are insured. Some are underinsured because their policy doesn't cover key benefits, but increasingly the problem lies with high deductibles and high cost sharing. We've accepted higher cost sharing year after year in an effort to try to hold premiums down, but as soon as we get sick, we realized what a failed strategy this is. Especially for patients with chronic conditions, high deductibles hit relentlessly year after year. Even modest copays will mount quickly, and as a result, people have difficulty affording basic care management for chronic conditions like asthma and diabetes, and as a result, avoidable and expensive medical complications arise. In short, underinsurance is becoming a threat to the public health. It also drives up bad debt and collections costs for doctors and hospitals. The industry experts tell us that the collections rate for low deductible plans is about 87%, but for high deductible plans is only 43%. So it adds to that administrative cost and hassle for providers as well. Reform can help by setting comprehensive standards for what health insurance covers and make sure that in the marketplace only good choices are available. A third choice is to assure affordability. In the interest of time, I won't belabor this point. I think the other panel talked very convincingly about the need for subsidies for both premiums and for cost sharing to make health care and health coverage affordable. The fourth goal is cost containment. Most private health insurance markets today are dominated by a few large carriers, and yet these dominant carriers have not used their market clout to control costs. Instead, they've passed on health care costs to consumers while increasing profitability at the same time. Reform can help by organizing health insurance markets to generate new forms of competition and more effective cost containment strategies. You have a number of options to consider. As is the case in Massachusetts, the exchange can have the option of not including all carriers as participants, but instead selecting those that are the most effective and the most efficient. As also was discussed earlier at great length, a public health insurance plan option can and should be offered to heighten competition. Finally, Mr. Chairman, transparency and accountability are critical to a well-functioning health insurance market. Mr. Deal spoke earlier this morning about price transparency and the importance of that, and I completely agree, but we need transparency throughout our health insurance system and markets. Health insurance policies themselves need to be transparent and understandable. Policies are so complex today, they leave most consumers confused and frustrated. A recent industry survey found that most people would prefer to do anything, including working on their taxes, rather than trying to read through their insurance policy to figure out what it covers. And we need transparency of market behavior as well. Too many market practices are hidden from view. It's very difficult to track who's enrolled, who's disenrolling, when claims are paid, when they're pended, when they're denied. These questions are important and they are answerable if only we will insist on the data. In an organized insurance market, we can do that. In the past few months, as financial markets and the economy have struggled, how many times have you heard or you yourselves made the call for greater transparency and accountability? These themes must also apply to health insurance and guide your efforts on health care reform. Thank you.
Thank you. Dr. Baker.
Thank you very much for the opportunity to be here. I'd like to draw a couple of key distinctions at the beginning. First, health is very different from health care. And second, health care is very different from health insurance. I know we've all hit on these points already, so I'll be brief. But we know many things affect health outcomes besides the health care system. By the time someone shows up at the hospital in critical condition, it's already too late in some senses. That means that comprehensive reform should address investment in all sorts of things that promote health, including health behaviors, access to nutritious foods, exercise, etc. It also makes international comparisons of health systems, particularly particularly difficult because when we look at the value our healthcare system is producing, the health outcomes are the product not just of that healthcare system, but of all those other factors that may be different across countries as well. The second distinction I wanted to draw was between health care and health insurance. And that sounds obvious, but it's often conflated in the debate. And this goes to the point that Representative Christensen raised earlier about what our responsibility and what our goals should be for helping sick people who are uninsured. People need health insurance because health care is uncertain, because the risks are uncertain, not because health care is expensive. There are lots of things that are expensive that we might want to redistribute resources for to low-income people, but not through the form of insurance, because those expenses aren't so variable, so unknown. Whereas health insurance exists to protect people against the risk of needing a lot of resources to pay for an expensive health care condition when those resources could save their life. So what do uninsured sick people need? They need health care, but they don't necessarily need health insurance. And we might want to design a reform to help those people that gets them access to care that doesn't necessarily build on an insurance system designed to help the majority of people who get insured when they're healthy, some of whom then fall sick and some of whom don't. The problem of the sick people who, the problem that sick people who are insured have is one of ensuring the affordability of that care going forward. People want protection not just against high expenses today, but against the risk of high expenses next year. And that means having an insurance policy that you can count on if you or a family member gets sick. Your premiums shouldn't go up, you shouldn't lose your insurance. You've done what you needed to do to get insurance when you were healthy. We need to ensure that that insurance stays around to protect people should they fall ill. A second principle I'd like to bring up is the idea that covering the uninsured doesn't pay for itself. It would be wonderful if we could recoup the investment that we make in covering the uninsured through less spending on emergency departments and inefficient care that we know the insured consume differently from the uninsured right now. Unfortunately, I don't think we can count on saving money by covering the uninsured, but that doesn't mean that it wouldn't be money extremely well spent. If we invest money in covering the uninsured, they'll gain enormous health benefits from it. So the money is worthwhile, but it's not free and it doesn't save money on net to extend insurance coverage because we know the uninsured are consuming too little health care today. So extending coverage to them would give them access to more care that would cost more money. So we need to design reforms that can pay for that. A corollary to that idea is that preventive care doesn't pay for itself by and large either. There are a few exceptions. Flu shots for toddlers more than pay for themselves. Most preventive care, again, is a good investment in health. It promotes health in the long run and it's worth spending money on, but it doesn't reduce costs. Most preventive care buys quality-adjusted life years at a pretty good price, and we should invest in that. Some preventive care is very expensive for the health that we buy and is in fact less cost-effective than care that wouldn't be characterized as preventive. So we shouldn't think of preventive care as a uniform cure-all either. It's a mix of highly cost-effective and highly non-cost-effective care as well. Another principle that I'd like to bring to the debate is that insurance alone doesn't guarantee access to high-quality care. We hit on that, the questions discussed that a fair amount in the first panel, so I won't spend a lot of time on it here, but there's ample evidence, largely derived from the Dartmouth data on variations in health care within Medicare, that high spending on health doesn't guarantee high-quality care, and even people in the same insurance program, Medicare fee-for-service, get wildly different health care benefits in different parts of the country. Next, I'd like to raise the idea that employees bear the burden of employer-provided health insurance. This means that if we want to foster the employer system, if we want to put employer-based policies on a level playing field with non-group markets, the reasons to think about doing that involve risk pooling and economies of scale in large purchasing, not the idea that employers somehow bear the burden of health costs through profits. In the long run, when healthcare costs go up for employer-provided plans, employees bear that cost in the form of lower wages. That's part of the reason we've seen slower wage growth over the last decade. It's because an increasing share of compensation that workers get has come in the form of health insurance rather than wages. In some cases, when wages can't accommodate that increase in healthcare costs, that results in unemployment. So ultimately, workers bear the burden either through lower wages or in some cases through losing their jobs. The last point that I'd like to make is that high-deductible health plans can introduce cost sharing that promotes efficiency, but they aren't the magic bullet. There's no reason to think that the high deductible health policies that we see today are the perfect structure. What I think the tax system should aim to do is promote innovative insurance coverage that fosters high-value care. That might mean higher deductibles for some kinds of care and subsidizing other kinds of care. Maybe we should pay people to go get flu shots because those are particularly cost-effective. It should have a negative copayment associated with it. Any reform design should promote that kind of high-value insurance structure that I think is unlikely to be generated by a monolithic single public payer plan, but is unlikely to be generated by a prescribed particular form of deductible. So in conclusion, I think we should address the issues of coverage and cost together, not because they're equally important necessarily, although I think both are very important, but because each goal is more likely achieved when the two are considered together. It's very difficult to design a system to cover the uninsured that we can afford tomorrow if we don't take healthcare costs into account. And if we don't get costs under control, more people will find themselves falling into that uninsured bucket as their employer-provided plan or the non-group market plans become less and less affordable.
Thank you, Doctor. Mr. Heiselmeyer.
Thank you, Mr. Chairman, and members of the committee for inviting me here today to testify. I have submitted prepared remarks, which I will summarize briefly. Let me just make a couple of points, and I'd particularly like to follow on what Dr. Baker just said about silver bullets. In 20 years of doing healthcare policy, it has been my observation that too often, too many of us, regardless of where we are on the political spectrum, are tempted to try to latch on to something as a small silver bullet solution to healthcare. I have come to the conclusion that while each and every one of those things has some value, none of them are a magic silver bullet to fix the problem. Rather, you have to take them in a context, and you have to look at them as pieces of the puzzle. We also have a tendency to run towards fads. That is the silver bullet, if you will, that is most popular at the given moment. Again, this can be on either side of the aisle. We've seen it with HMOs, HSAs, public plans, this, that, and the other. Again, I would encourage you to refrain from that. In looking at the situation we have today, what strikes me, not only based on my experience over 20 years, but actually based on the last 5 years of working with about 18 different states, literally I was in the period of 7 days testifying in Anchorage and Tallahassee, so it's across the country in very different circumstances, how diverse the situation is on the ground in your different states, and also how much more amenable it is to solution at the state level. I've also, on a policy level, been intrigued by the few things that are really needed, in my view, to make measurable progress. And let me summarize them as I do in my testimony. I think the Massachusetts connector, which is the first example, and now Utah, unfortunately, Representative Matheson isn't here, last week enacted something very similar, is the first couple of examples of what I think needs to be done in one area, which is to create an individualized solution for employers and their workers. This is not the same as the traditional individual insurance market. As Mr. Kingsdale points out, this functions just like an employer market. You're guaranteed the coverage. You have a right to pick it at open season. In fact, it works like FEHBP, which was discussed earlier. In fact, they are doing the things you would have to do if you were to say, we're going to take FEHBP, and instead of having it be one employer, the federal government, we're going to have a state do it for any employer in the state to participate in. That is what the unsubsidized Commonwealth connector reforms that they are rolling out right now are designed to do, and what other states are looking at doing. Any state can do that today, and we've shown them how they can do it working as Massachusetts and now Utah are doing within federal law. Point two is if you want to apply guaranteed issue to the individual market, that can be done. It can be done at the state level. Some states have done it, as Ms. Kaufman pointed out. It could be required at the federal level. The important thing is to do it right. It should not be an unlimited, pick it up, drop it anytime you want kind of guaranteed issue, but rather, as the federal government set forth in HIPAA, a set of standards for guaranteed issue in the group market for individuals when it is reasonable for people to do that. The other 2 points are in my testimony are that the way to make those reforms work in an optimal fashion is to support them with risk adjustment mechanisms. And I've noted in my testimony that in my discussions with folks in Massachusetts and in my observations, I think if I was to go back and say, what did they leave out that they should have included, and that was they didn't include a risk adjustment mechanism for making sure that nobody was disadvantaged by getting, as an insurer, getting more of the sick cases than somebody else. Interestingly enough, learning from that lesson, that is the first order of business in the Utah reforms, is to set that piece of it up. And then finally, if you are going to move to guaranteed issue in the individual market and you are going to give people the right to buy coverage, then for that to work economically and socially, people have to take the obligation to take advantage of that right when they are healthy and pay into the system and not simply avoid it until they need it and then want to take out of the system. Finally, what strikes me about all of this is that any of this stuff and all of this stuff can be done by states now. It is not necessary for the federal government to do it for them. The federal government, however, could do things to aid and encourage them, and I'll be happy to discuss that later. And then finally, to Representative Deal's question, again, I think price and transparency is essential to making this work even better down the road. But again, I think this is something, given that states regulate insurance and the practice of medicine, that states are looking at doing themselves to one degree or another, and is certainly something I would encourage there to support it. Thank you.
Thank you, and I want to thank all the panelists. We're going to have questions now. Each member gets 5 minutes, as you probably know. And I'll start out with myself, and I wanted to ask Mr. Kingsdale, you have achieved remarkable results in Massachusetts with your two connectors. Our national rate of uninsurance is 17%. In Massachusetts, just 2.6% are uninsured. But to achieve this result, you have in place a requirement that all residents must have health insurance coverage that meets minimum standards for adequacy. And I just want to ask a few questions about this individual mandate and how you ensure that the coverage people are required to buy is affordable. First, what type of coverage does, I have 4 questions, so I'm going to try to go quickly here. What type of coverage does Massachusetts require its residents to have, and how is that individual mandate enforced? Of course, I heard about this during the presidential campaign, but I want your opinion.
Sure. Thanks for the question. So we have, if you require insurance or anything, you have to set a minimum standard. Obviously, $1 of coverage per year does not constitute real insurance. And that's been one of the 2 thorniest problems, which the legislature, in its wisdom, asked the board of the connector to resolve rather than to do in legislation. And we have used a couple of principles to develop what I would call minimum creditable coverage. One is that, like any insurance, it ought to protect people from catastrophic costs. So there are some maximum cost-sharing elements to it. And the second is that because this is health care, which does differ in some important respects from other kinds of insurance, we actually require coverage up front of preventive care before a deductible, and coverage with or without a deductible of a broad array of services such as you would expect from coverage in your own health plan.
And how about the enforcement of the individual mandate? How
So
do you do that?
the enforcement is through the tax code. The enforcement has been on the principle that it's good to have insurance and we want to help you get there, not gotcha. So the actual requirement went into effect July 1 of 2007. As long as you had insurance by December 31st of 2007, you did not pay a penalty, and if you did not have it, the penalty was pretty modest, $219. That penalty goes up and becomes month by month as we move into 2008 and 2009. We have exceptions for religious beliefs, a much bigger exception for affordability. Of course, we have significant subsidies to low-income people who are not eligible for employer-sponsored insurance to help them afford it. And then we have a robust and generous appeals process for individual cases. So we look over backwards to try to get you there rather than penalize you for it.
Let me see if I can get to these other 3 questions. How did the state decide what combination of premiums, deductibles, coinsurance, other out-of-pocket payments were affordable for individual and families?
That's the other very tricky question. Again, the legislature asked the Connector Board to do that. And we kind of did a bookends approach. So at the bottom of the income scale, 0 is affordable, and we defined that as 150% of federal poverty level. That's a fairly arbitrary decision, but a gut check. And at median income, and ours is a wealthy state, so that's about 550% of federal poverty, we said you have to have insurance. There is no exception for affordability. And in between, we basically do a scaled progressive schedule, but the principle underlying that is that by the time you get to 200 to 300% of federal poverty, so that would be an individual making $21,000 to $32,000 a year, where 80% of our citizens who are get their insurance through employer-sponsored insurance pay something like about $100 on average per individual per month toward that. We thought that was a reasonable affordability basis. It had political equity. It would reduce or avoid crowd out, and it seemed sort of gut check fair.
Now, what about, have any studies been done to determine if rates of medical debt or bankruptcy have declined since Massachusetts achieved this near universal coverage?
It's a great question. I actually have asked several times to have such a study done. It's on somebody's project list, and I keep looking for outside research to do it. I'm hopeful that the answer would be medical bankruptcies would go way down. You compare 08 to 06, but we have not done the study.
Well, let me just ask Ms. Politz this issue again with the individual bankruptcy or debt. There was a study published by the Center for Studying Health Systems Change that showed that 75% of those with medical debt in 2007 were actually insured. They had health care coverage, but they still had debt. Can you explain that? I mean, this whole issue of people who actually have coverage going bankrupt or going seriously into debt.
It can be a number of different factors. It could be that their policy doesn't cover all of the services that they need. It may not have a prescription drug benefit. For example, if you have HIV and you don't have a prescription drug benefit or MS or something that has a very expensive pharmaceutical need, then you could run up very high medical bills because those services aren't covered by your insurance. There may be caps on what's covered. You see policies that only pay so many mental health visits a year, and then, a kid gets an eating disorder, or a policy that, caps total benefits at $10,000 a year, and then you have a heart attack that costs $100,000. So that can happen. Typically, the literature on medical bankruptcy suggests, though, that it's not six-figure medical debt that is sinking families. On average, it's less than $12,000 or $15,000 in medical debt that'll run a family over the limit and lead them to declare bankruptcy. And so we need to also look at cost sharing, and cost sharing that we might think of even as modest. One study that I cited in my testimony looked at medical copays in the range of $6 to $25 and what those meant for people with chronic conditions, asthma, diabetes, and so forth. If you're needing to, take medication several times a day, every day for your entire life, and you're always refilling these prescriptions, those little copays add up and become thousands of dollars. And if you add on to that deductibles, copays for other medical care that you need, it really adds up remarkably quickly.
Okay, thank you. Mr. Deal.
Thank you. I want to get my transparency question out of the way real quickly. I think most of you were in the audience and heard my description of the proposed legislation. And I just go down the list. Do you generally believe that pricing transparency is something that we need to enhance in our system, regardless of what that system may ultimately turn out to be? Ms. Kaufman, start with you and we'll go down.
Thank you. I think it's critical when you have a private market to have transparency, to provide consumers with useful information they can understand and use in making decisions. Right now, if you were shopping around, you couldn't get your policy ahead of time, the full contract. You can get a benefits description, which may or may not be accurate. So transparency, in my view, includes everything from how your contract, how your insurance will work when you need it, to choosing your provider, and to making more informed choices from start to finish. Right now, that just does not exist in the private market.
Dr. Kingsdale.
I would strongly endorse the idea of making prices and benefits and everything else transparent. In fact, in our programs, that's exactly what we do. I've been in the insurance business for over 25 years before becoming a bureaucrat, and I'm pretty realistic about how much is achievable. Price is absolutely, and other information, requisite to a functioning market, but so is competition. In Ms. Kaufman's state, and in most towns in my state, you don't have but one hospital, period. So you can know all you want about their prices. You really don't have a choice, and so it doesn't do you much good.
Right.
So I'm realistic about what you can do with it.
But even in those situations where there's one hospital, who you are and who's paying the bill will determine what the price from that one hospital is, because you've got negotiated prices by government agencies, you've got negotiated prices by private insurers, and generally the ones that wind up in the bankruptcy court are the ones who don't have anything, and they generally charge the highest price of all. Ms. Politz?
I agree it's very important, and I commend you for your legislation, and I would just agree also that looking at all of the dimensions where transparency is necessary is important to do, and I hope that'll be part of this effort as well.
Thank you. Dr. Beck?
Agreed. Transparency is a prerequisite for a well-functioning market, and the prices that we could publish now would be very useful, and even more useful would be building together bundles of prices that would really let people choose how much does it cost to have this condition taken care of by this group, not line by line that's harder for them to aggregate, but you have to start with what's available.
Right. Mr. Hamsler?
Yes, Congressman, as I mentioned in my remarks, I do agree with you on that. I would simply, as I mentioned in my remarks, encourage everyone to recognize that this is one very important piece of the puzzle, but it's not the only thing. To follow up on what Mr. Kingsdale was saying, the first question is, what does it cost? The next question is, what am I getting for my money? And that's where you start comparing the data on quality and outcome. So you always have to ask that first question before the second question gets asked. That's true. There are ways where you can do that, not only in insurance, but also in the provider side, which is really important. And I would also encourage folks to think not about the consumer versus the provider interaction, but creating a common data set that all the insurers can use to act as the agents, as the experts on behalf of the consumers in these decisions. And so a number of states are looking to do that. And I think the regrettable thing about it, if Massachusetts' mistake in the beginning was not to have a risk adjuster, their mistake in implementation was that the governor and this administration recently cut back the Cost and Quality Commission that was designed to do that in the legislation.
Could I follow up with in less than 3/4 of a minute? Would you contrast the Utah situation with the Massachusetts? What improvements did you think they made that were important? What other changes, if any, would you suggest a state look at?
Well, I think the most striking thing about this, and you all as members of Congress will probably think of the very different politics of those states, but I would encourage you to realize that the most striking thing to me about this is when you rank the 50 states by the per capita cost of health care, Massachusetts is the single most expensive and Utah is the absolute cheapest. So those are vastly different in their health care systems. That said, Massachusetts had a large amount of money that it was giving to hospitals, public dollars, to pay for the uninsured, which is now being converted into buying those people insurance. Utah's on the other end. They have almost no public money going to insurers. So what they are doing is, while Massachusetts focused on expanding coverage by subsidizing low-income individuals with the dollars they already had, and is only now rolling out the reforms to allow employers and unsubsidized workers to have a choice of coverage. Utah is going about it the opposite way. They're starting in the private market and then working towards the public side. That's my point, is states are very different. Each can use the same things, but they have to find their own way and their own order for doing it that suits them.
Thank you.
Thank you, Mr. Deal. Mr. Gonzalez.
Thank you very much, Mr. Chairman. I apologize to the witnesses. There are so many conflicting appointments today and another hearing in judiciary, so I missed the testimony of the witnesses, except for the first witness, and I apologize. I may go over something that y'all covered, and again, Do understand, though, that you have written statements in here. We have memos that are prepared by staff. We're going to have many hearings. Much of what you say here today, if not listened to by individual members of the committee, believe me, these statements will be reviewed and may well serve as the basis for some of the memos in the future as we take on different panels. I'll start with pronunciation. Is it Dr. Baker? How would you pronounce that?
Baker.
Baker, okay.
Just spelled funny.
No, it's spelled in a very interesting way. But you were here for the witnesses' statements by the previous panel, were you not?
Yes.
Okay. And in your own statement, and I couldn't agree with you more, and I'm sure everyone that's here, in your statement you indicate, while there are many open questions in the design of the ideal system, with millions uninsured and rising costs threatening to swamp public and private budgets alike, we cannot afford to wait to act. Obviously, this committee is going to move forward. This administration is going to move forward. But I think you highlight the biggest obstacle, and that is something I referred to earlier when I was quoting from the two authors from the Harvard Business Review, an old article, no doubt, but we still face the same problem. How one balances these trade-offs is likely driven as much by philosophy as economics, and any reform will involve tough choices between competing values, and I think that is the biggest problem. If we can just stick on the economics, the efficiency, efficacy of what we do, we're well served. But you've already heard words like socialism in the Big Brother and such. We need to get past that. So the question is, do we move forward now? And we do so. We're not talking about a single payer. Is that correct? That's not. Now, there are many here that would like that, but I'm just saying my vision is not. It's going to be a public option. That's the way I like to think of it. And as we move forward, again, leaving back ideologies, we've always said that we probably could form the most efficient system if the employer, which is the greatest purchaser of insurance, could lead that fight. That's what I had in the Harvard Review article, but that hasn't transpired in the past few years. So employers haven't been able to identify a better system. The consumer is ill-equipped. Ms. Politz, thank you very much for your comment. It was very sad in that Time article about someone from San Antonio who had an insurance policy that was totally worthless when his kidneys failed. So you can't say that the consumer is equipped to deal with this. The health care providers aren't doing it, not the medical professions. As a matter of fact, we have the specialties that compete with one another depending on what's going to be covered and when and how much. So wouldn't it be appropriate for the federal government, and I know someone has suggested let every state do it individually, but what are your views today about where we're going and what we are going to be proposing as far as the federal government coming in and playing a major role? Yes, Dr. Baker.
Thank you for the question. I think you've hit on so many important issues. One of the things I'd like to pick up on is that there are things that we cannot expect a private market to do. Private markets are great at pooling risks, and there are regulatory requirements to ensure that they do so fairly and effectively, but we can't expect private markets to redistribute money from rich to poor or from people with low health risks, the healthy, to people with high health risks, the sick. That kind of redistribution of resources is fundamentally social insurance, not private insurance. Social insurance need not be socialized. It could be done through the form of risk-adjusted vouchers, where people with high health risks take extra money that they're given, maybe particularly low-income people get more generous risk-adjusted vouchers to ensure that they have access to the care that they need. That kind of redistribution happens a little bit now because of the way that we subsidize employer-provided health insurance. The way that we subsidize it encourages some risk pooling in the employer market by encouraging high-risk people and low-risk people to stay in the same pool, whereas otherwise low-risk people might flee. Now, is that the most efficient way to do that kind of subsidization of high-risk people? There are probably other ways that we could accomplish that goal that might have better distributional implications while preserving what's good about the risk pooling that's occurring right now. Any reform going forward that's going to take care of our most vulnerable citizens is going to have a component of social insurance, and that's the way we should be thinking about that function, not trying to impose that on private markets that are ill-equipped to do redistribution.
Thank you very much. I yield back, Mr. Chairman.
Thank you, Dr. Burgess.
Thank you, Mr. Chairman. Dr. Baker, if we could just continue on that line for a moment. One of the things that was talked about in the fall campaign was using the best practices of the states that have high-risk pools and trying to construct, or constructing rather, a mechanism for dealing with individuals who had conditions of medical fragility that would apply to their unique situation without changing the landscape for everyone else. Is that still a realistic possibility in the environment that we find ourselves today, taking the best practices from the states that have high-risk pools?
I think we certainly want to learn from the diversity of state experiences, and some states have high-risk pools that are functioning much better than others, and there are some general principles we can draw from that, more broadly subsidizing the high-risk pools rather than trying to subsidize them from narrow tax bases, for example, seems to be a more productive way of subsidizing them. Again, that is falling under the role of social insurance, where you're explicitly trying to redistribute some money to high-risk people who are uninsured, and the first goal, who are otherwise uninsured. I would think the first goal of a reform would be to get people insured as early as possible while they're healthy, so they can invest in their health, so they get the most efficient care they can, and a system that's designed to minimize the number of people in that condition in the first place could spread dollars a lot further. Then I think it would be great to learn from best practices at the state level to deal with people who fall through the cracks and to ensure that there's a broad enough subsidization that it doesn't drive a cycle that leads to more healthy people being uninsured, for example.
Okay, thank you. Dr. Kingsdale, on the Massachusetts experience, do you have a figure on the number of people who are paying the fine rather than buying the insurance?
So we have a lagging indicator because you file in April, of course, for the year before, and some people get extensions. So we have it only for 2007, and that was about 100,000 people. So
and so you'll
1.5% of our population.
And then you'll have comparable data that you'll generate. This is your filing period, April 15th, like the federal income tax.
Right. Although about 10% extend till October, but we'll have pretty good data.
Yeah, I do that too.
Got to try that.
Mr. Asselmower, if I could ask you on the, you pointed out that a lot of things are being done by the states now that they have a great deal of flexibility. In fact, I think we gave them a great deal of flexibility in the Deficit Reduction Act in 2005. Ezekiel Emanuel, writing with Ron Wyden in the Journal of the American Medical Association in October of this past year, alluded to that, but said the one thing the states cannot do is to alter the federal tax code. That is not within their power to do that. So could you speak to that?
Sure.
We heard a lot about taxing health benefits during the fall campaign. It appeared to me at the time to be something that was disfavored by the parties that won, but now it seems to be coming back in vogue, and I wonder if you might just address that.
I think it all depends on what you do with the money once you've taxed them. Most of the proposals I'm familiar with, and I've worked on about 8 different ones over the years for everybody from Mr. Army to Mr. McDermott on changing the tax treatment in Congress, would redistribute the money in the form of new tax credits to address some of the equity issues that were addressed earlier. The illustration would be the unsubsidized Commonwealth choice plans that are now being rolled out in the connector in Massachusetts and is envisioned in other states, whereby an employer would say, look, instead of offering a group plan, I'm going to take you down to the connector, and you will each, as employees, have a choice of that menu of plans that they have on offer, and you pick what's best for you. It's all guaranteed issue. If you leave me, you're still in the system, you still have your insurance, you take it with you, et cetera. That is structured in a way that under federal employee benefit law, it qualifies as employer-sponsored insurance and therefore qualifies for favorable tax treatment. The problem becomes that favorable tax treatment is essentially the deduction against income and payroll tax. So if you're a lower wage worker who pays no income tax, that's worth 15 cents on the dollar to you. If you pay, say, that's your payroll tax. If you pay the employer-employee share 15 cents a payroll plus you're in the 15% income bracket, it's now 30 cents on the dollar, up to like 50 cents on the dollar for somebody who's maybe making $100,000 in the 28% bracket, et cetera, or 31%. So the idea of tax reform is to change that to redistribute the money more equitably. The state can only maximize their citizens access to those federal benefits. They can't change the federal benefits. There are other places in federal law where you could make changes that would aid the states.
Just one quick question. There, as I understand it right now, there's not a public option plan in the federal employee health.
No, there's no public option.
Would there be an advantage to putting a public option plan on the?
Well, my approach to the public option plan is it strikes me as one of these sort of fad and silver bullet things that go around, as I talked about earlier. I look at it this way. No matter how you cut it, the government always sets the rules. Now, you in Congress have a set of issues because some of the rules are set at the federal level, like federal employee benefit law in ERISA, HIPAA, COBRA, tax treatment of health care, the Medicare, Medicaid program, okay? But then other rules like licensure of providers, regulation of insurance is done at the state level. So your issue is which one's going to set which set of rules. But beyond that, you then have this issue, whether it's federal or state, if competition is going to work, everybody competing has to be on the same set of rules, right? Okay, now you get to point 3, which is, okay, can the entity that is inherently the rule setter field a team in the competition and have that fair? Are they going to, is a public plan going to have to meet the solvency requirements that a private insurer would have to meet in Ms. Kaufman's regulations? Are they going to have prompt pay laws? Are they going to have the same, can you sue them, or is sovereign immunity going to prevent you from suing them? When they deal with doctors, is it purely on a contractual basis, or is it like Medicare where if the doctor does something you don't like, you can say it's criminal because it's fraud? I mean, these are all questions you have to work out, and depending on how you answer them will depend on what it'll work on.
We've got to move on here. Thank you.
To coin a phrase.
Ms. Castor.
Thank you, Mr. Chairman, and thank you to the panel. Your testimony has been very thoughtful. And I was glad that you raised the value of the premium dollar for individual health coverage because I'm very skeptical in the individual market that consumers are getting the value of the health benefits they need. And I've read testimony and understand a lot of that dollar that consumers pay is going for other purposes other than the health of that individual. And Ms. Kaufman testified that in Maine, insurer administrative expenses have more than doubled in the past 8 years. This is at the same time when all across the healthcare spectrum, the premiums are going way up, and what you receive, what a family receives, just isn't what it used to be. And you also noted that in the past 3 years, the state's largest insurance carrier has declared $152 million in dividends. So as regulators and experts in the individual healthcare market, tell me, on average, how much of the individual health insurance premium dollar is spent on covered medical benefits, and how much is spent on marketing and administration, including high executive compensation and profit? And then how does this percentage or medical loss ratio compare to the medical loss ratio in employer group health insurance products, and what explains that difference, and what do you recommend? How can families and consumers get a better deal? Why don't you start?
Thank you very much for your question. I apologize for my voice. I'm trying to get over a cold. In Maine, we have 65%, 65% medical loss ratio requirements. We have 2 companies in the individual market. One was not meeting the 65% loss ratio. They paid out, I think, 50-some cents on every dollar they took in for medical. And so exercising my authority as a state regulator, I ended up requiring them to refund the extra premiums they collected, and I also fined them $1 million for violating the state law. The other major carrier, which is the majority of our market, they pretty much pay out over 90 cents on the dollar that they take in medical. Now, there's been a whole lot of discussion about the cost of guaranteed issue and adjusted community rating requirements, those protections that allow sick people to access the private market. What that means is a lot of what the carriers take in, they do pay out in medical claims, but they also achieve healthy profits from being in the private market. Earlier, you heard that the private insurance market isn't really set up in a way that where carriers can assume too much risk. I would say if you're going to have a private market where insurance companies are allowed to profit, it's equitable and fair for them to take on risk. And we shouldn't expect taxpayers to pay for the sick while insurance companies are very profitable and make millions and billions of dollars in the industry. So if you're going to have a private system, the carriers have to assume the risk and the taxpayers should not bear the burden.
If I could add to that, I think it's to your question about how much administrative costs in the non-group market, it's highly variable with the rules that are set up. So in Commonwealth Care, our subsidized program, this is really kind of individual insurance, individuals sign up, our administrative costs, their administrative costs run about 8%. In the non-group market more broadly, in Massachusetts, they probably run twice that, maybe 12%, something like that, maybe not twice. In California, I'm told brokers earn 10% just for their services. So it depends very much, market by market, what the market rules are. And of course, one of the great things, potentials about the connector, remember my 20 to 30 minutes shopping, it's all on the web, is we can take the distribution costs of non-group insurance because they are very, very high, even without large commissions. In an unorganized market, they are just very high. There are no scale economies. It's a one-on-one, hand-to-hand combat kind of situation to sell a policy and explain it. We can take those way down, and if you had scale economies with, on a national level, millions of people buying this way, you're talking about a couple of percentage rather than 10, 15%. But it does depend on the rules and how you have structured the market.
Thank you.
Mrs. Castor, could I comment on that as well, or do you?
I'm sorry, you can comment. Sure, go ahead.
No, I'm sorry. This question comes up at the state level a fair amount, and I just would want to make the observation. I have suggested to states that what they could do, and in fact, John, you might be able to do this in the connector too, is to simply publish, apropos of the transparency, the loss ratios, and you publish what last year each company for each plan paid out in claims and what they retained for administration, profit, et cetera, with the proviso that you let them buy it down. So in other words, the dollar of premium that was either paid out in claims or refunded to the policyholders. Now, in that kind of a world, imagine you have two plans that are pretty much the same and cover the same benefits, et cetera, but one does a better job of managing care than the other. Okay, and the one that does a better job of managing care costs $4,000 instead of $5,000, but to get that care managed, their loss ratio is 70%, not 80%, because they had to spend more on administration. Which would you buy? Would you buy the one that spent more on administration but produced a $4,000 premium because they did a better job working with providers to manage care? Or would you buy the plan that was $5,000 but paid 80% out in benefits? If you put the information out, people can make those decisions, would be my suggestion.
Thank you. Mr. Gingrey.
Thank you, Mr. Chairman. Dr. Kingsdale, in regard to the Commonwealth Health Insurance Connector, I was curious to know, in comparing the Commonwealth Care versus the Commonwealth Choice, what has been the experience in regard to what consumers are choosing? Maybe that was in your written testimony. I did read it, but it was the wee hours this morning. But what is the breakdown at this point?
Yeah, they're two very distinct programs, so it's going to be hard for me to, I think, answer your question in a way that's going to satisfy probably the intent. So the 4 health plans that are available, and now we just could open that up to competition because they had restrictions in the original legislation, so we're adding a 5th. The first new entrant, major new entrant into the insurance business in Massachusetts in decades. But those 4 / soon 5 all basically serve Medicaid and lower income folks. And while 2 of them also participate in the unsubsidized program that has...
So your Commonwealth Care is a subsidized program.
Right. And the Commonwealth Choice is unsubsidized. That is dominated by commercial insurers who are not in the low-income Medicaid.
So they really don't,
They're really very separate.
The patients or the consumers don't have a choice. It depends on their income status. If
Right.
they need a subsidy, then their choice is care.
Right.
If they don't need a subsidy, then their choice is choice.
I'll take a stab at one thing that might be helpful, which is because of the transparency and because the price differential, the premium differential, is 100% borne by the individual making the choice, there is disproportionately large purchase of lower price plans, even though the lower price plans may have by far much less brand name recognition than the higher price plan offering the same.
Well, let me ask you this follow-up. In regard to that, in the care plan, the subsidized plan, I guess physician fees, reimbursement rates for provider care is set. And are you finding that the many physicians, the acceptance rate of the care plan in the Commonwealth is pretty high?
Well, yes, and that's
are you running into problems with that?
Not really, and that's part of an ethos of shared responsibility. There is tremendous support for this program among physicians, hospitals, insurers, employers, et cetera. All but 2 legislators, all but 2 of 190 voted for the thing. But the Medicaid MCOs that serve that lower income population Commonwealth care, while the fees are not set, so they can get negotiated up, kind of the reference point, the starting point that people have in mind when they start those negotiations are Medicaid fees. And they say, oh, you're going to pay us 10% more than that, as opposed to the commercial side, where they might say, oh, we're starting at 150% of Medicare.
Right.
So it's a bifurcated set of negotiations.
Well, the reason I ask that question, of course, as we go forward and we're looking at all the options and hearing from all the experts in regard to the federal exchange connector, if you will, and the public option plan. I just wonder if physicians are not forced, if they take any patients within the exchange, that they would also have to take the public option. But if not, and those fees are set so low, then you're going to have a lot of resistance, a lot of pushback. And again, what we're saying is, what good is that card if there's no doctor that's going to accept the public option? So that's a concern of mine that other than the additional concern of the crowd out. Let me shift real quickly to, I've already messed up once today on pronouncing one of my colleagues' names, but Doctor, I wanted to ask you on page 3 of your testimony, you speak at some length about market reforms that would, quote, realign insurer incentives away from avoiding risk and toward maximizing value. And you cite in your testimony the need for risk-adjusted mechanisms to ensure the market works smoothly and fairly for all insurers and policyholders. It would seem to me that these market reforms that you talk about in your written testimony might address some of the major breakdowns in health care today without requiring government control of care. And I would like, in the 15 seconds left, could you elaborate on these risk-adjusted mechanisms a little bit more, if the chairman would bear with me?
Yes, sir. Very simply, and I referenced 2 papers that I in the footnotes in this testimony that are on our website that I wrote on the subject, if you want to go into it in more length. But essentially, in a market that is underwritten, where the insurer can turn you away, okay, what we have created is a high-risk pool that says, well, you can be guaranteed issue into there. Okay, so the person gets sent, who's sick gets sent over there. All right. If you have a market where the insurers can't turn you away, as we're talking about in the employer group market when you go to the connector, or if you were to expand guaranteed issue to the individuals, then you can't send the sick person off there. So what you do is you create essentially the same mechanism. It's just the insurers get in a room together and they put in the pot all their claims. I got 5 diabetics, you got 3 cancer patients, and we're going to sort it out and do it in a fair way. Now, there are many different ways to do that, but that's essentially the concept behind it. And my point is, for the market to work well so that the insurer can say, hey, you know, I do a good job of treating diabetes. I can help coordinate your care so you get better results at a lower price, and then they get all the diabetics and somebody else gets all the cancer patients. Well, they can work it out in the back room on their own. That's what a risk adjuster pool does, okay? And it spreads the cost among everybody else, as opposed to saying, well, you're sick, go there, and then we're going to spread that cost over everybody else. So it's the same concept, it just depends on the market you have. Again, the papers discuss it in more length.
Thank you. I know I'm going to have to stop you because they're telling us we are going to have votes, and I want to get the last two members in here. Ms. Capps?
I'm sorry. Thank you very much. And I just got a tip, but I also have some questions I want to ask. This has been a very interesting panel, and I appreciate your contributions, each one of you. I will single out two people because 5 minutes goes very quickly, but I understand, Ms. Paulus, before I ask you my question, which I'm very interested in your response to, that you never got to weigh in on the risk adjustment or risk insurance.
Well, I didn't think I was asked, but...
No, I'm asked, that's why I'm giving you a chance to, if you could briefly do it. If you'd...
Sure. I think reinsurance is a mechanism that has been tried on a voluntary basis in a lot of insurance markets, and public reinsurance has been tried in a few states as well. It's simply another way to subsidize health insurance at the end of the day if it's public reinsurance. Instead of subsidizing the premiums, which come regularly on the first of every month, you need to sort of reach in and find somehow the high-cost claims or the high-cost patients. So it, I think, can achieve the same thing. It is more complicated. There are many more transactions involved. At the end of the day, you need to make sure that if the end result is to subsidize the premiums, if that's what you want, to have the premiums reduced, then you need to have very, very good transparency to make sure that all of those savings from the reinsurance actually find their way back into reducing the premiums. Otherwise, you know, kind of like we're having with AIG now, you're putting a bailout in and you're not getting the result that you want.
Okay, thank you. Now, could I ask you the question I had intended, because, and you'll understand why when I tell you where I'm coming from. I'm hesitant about proposals that suggest that people should just purchase insurance in the individual market, whichever state they are from or wherever they are, because there are states like California that offer much stronger minimum protections for insurance. For example, California mandates screening for osteoporosis, while most other states do not. That happens to be a topic I'm personally very interested in. California also requires private insurers to cover treatment for eating disorders. More than half of the states do not. So that would make a huge difference to Californians if they got their insurance in another state that then refused to cover, and they came to California and refused to cover that. Wouldn't a public option be able to account for variances in state protections and be more consumer-friendly? Also, couldn't a public plan be formulated in a way that protects the strongest minimum coverage provided to individuals so that you would get the benefit from living in a state where these things were mandated?
It is absolutely up to the Congress to determine whether you want to set these standards at the lowest or the highest common denominator or somewhere in between. So you absolutely could create a public program that provides for comprehensive coverage so that people get the care they need everywhere. And I would defer to Mila on the other issues about selling coverage,
right,
in addition to the concerns about not being able to access benefits. I think there are real questions about, and I have enormous respect for Mila, but whether she has the resources to enforce against a plan in California, or a resident of her state who would buy 3,000 miles away and then get into trouble. I think there would be very difficult.
And some of us in states like California are worried about the opposite. But I can see it going both ways. For example, people who work so hard in California to do the things that, like what I've just mentioned, this would be a huge step backward if we would be forced into what we would consider a step backward. But I also want to, I'm going to need a little extra time, Mr. Chairman, because I kind of did something else too. But because, Ms. Kaufman, I'm really interested, you can speak to this one issue if you'd like to, but I wanted to learn more about programs that you have been able to create, which bridge the gap between Medicaid-covered individuals and those who are uninsured but don't quite qualify for Medicaid. For example, I'll tell you where I'm coming from in my district. In fact, in each of the 3 counties I represent, we have seen some very innovative proposals, such as county organized health systems, which better capture all Medicaid-eligible individuals, and using a sort of a managed care model, a nonprofit, but a locally organized one. And also then there's another program in Ventura County which refers to the person I acknowledged this morning in my opening statement. Because she lived in Ventura County, those who are uninsured but don't qualify for Medi-Cal or Medicaid in Ventura County have access to another program, and they've seen such a dramatic decline in emergency room visits for non-urgent care as a result. And that's the kind of outcomes we should strive for, because they can put that money back into this system and help extend it to more individuals. The reason it works, and this is what I would like you to verify or add to, is because it's public-public partnership, whereby the local government can provide the innovation and creativity in creating a system that works best for their particular population. Can you talk, I know it's briefly now, about how you've done this? How have you managed to tailor a plan that Maine really benefits from?
We have a slightly different partnership, public-private partnership, which I call a bridge program. It's called Dirigo Choice. Right now, due to funding challenges, it's not open for new enrollment, but essentially the state helps to pay for the premiums. There's a private insurance company that provides the coverage, but it's the Dirigo agency that negotiates the benefits, the price, and people who really can't afford the private coverage but are working and make too much money to qualify for the public insurance program, that's the place where they can get coverage, where there's a private payer that pays their medical bills and the state helps them with the premiums. The program has served over 23,000 people, both small business workers, their families, as well as individuals. Unfortunately, because of funding challenges, it hasn't been open for new enrollment, and as premiums have gone up even slightly in that program last year, I believe it was 11%, which in our market is slight. I can tell you that the major carrier recently came in with a premium increase of 40%, and actually that was for their consumer-driven product, higher than the other products they sell. So 11% premium increase for the Dirigo Choice is not as high as the rest of the market is asking for, but that forced some people to leave that program because they just couldn't afford even the 11%. Due to limited incomes, their wages have not gone up, and everything else has gone up, the price of food, gas, energy. So it's been really difficult, absent a strong and real financing mechanism. There's been a lot of talk here that states could do this. If we were able to address...
I'm going to have to cut you short because we have one more member and we have 3 votes, so...
Could you finish your sentence? I just want to...
Sure, go ahead.
States need help. If we were able to tackle the healthcare crisis, we would have done it. We want to do it. We cannot do it alone. Despite Ed's comments earlier, we need help, and we want to be your partners in tackling the healthcare crisis.
So to make this work, there are times when the federal government should just really shift the balance a little bit more when states are having a hard time. Or that's one of the ways that it could survive. Okay, thank you.
Thank you. Mr. Shadig.
Thank you, Mr. Chairman. Ms. Kaufman, I just want to make sure, did I hear you earlier say that there are only 2 carriers in the individual market in Maine?
Actively selling, that's correct.
Tragically, I think that's the situation in most states, where people forced into the individual market have almost no choice whatsoever. A public plan which they could buy as an individual would be another option for them that would give them at least one other choice? Is that you understand?
Yeah, people want real choices. To the extent that the public plan offers good coverage, adequate coverage that pays for you when you're sick, that is a real new option that people would benefit from. I've talked to providers and individuals alike, and people are losing faith in the private market. There's this perception out there, because the profits have been so high, that claims decisions are not made in the best interest of the insured person. And I can tell you they are, but the perception there is not the reality. And I think many people would choose the public option because of those reasons. And I think the public option would give would
I understand
mean
that.
real competition for the private plans out there.
Well, I believe that there have been instances where benefits have not been paid in the interest of the beneficiaries. Indeed, I conducted a long campaign against HMOs, who I think were denying care to try to make profit. But we have people forced into the individual market often because of the tax treatment. Some people can get health care inexpensively through their employer on a tax-favored basis, but if you go buy it in the individual market, you pay with after-tax dollars, making it much more expensive. Would you then favor mechanisms that would create other group purchasing options so that people could pool through a mechanism other than their employer?
I think we need a more equitable way to help people buy coverage, and people shouldn't be disadvantaged because their employer doesn't offer, or they're
I couldn't agree more.
in the individual market. I think in terms of pooling, the price of pooling in itself doesn't get you anything unless there are real protections and oversight around pooling. So I would be very supportive of increasing and incentivizing more pooling, as long as there are real protections for people who want to be in those pools.
Mr. Hasemeyer, high-risk pools. As I understand it, you just tried to explain or discussed with Dr. Burgess the issue, or maybe it was with Dr. Gingrey. People who are high cost can either be put in a high-risk pool or kept within the existing pool of insurers in a given state. Is that what the paper you discussed addressed?
Right. Basically, what you're doing is you have both of them, a high-risk pool or a risk transfer pool, are mechanisms for pooling on a market-wide basis. So you start at the individual insurer level, where they say, well, I get some sick people and some healthy people, and there's a cross-subsidization of the sick by the healthy. The next step is to say, well, we're going to take all the insurers in the market, and we're going to do this same sort of cross-subsidization for the whole market, defined however you want, a region, a state, whatever, but for purposes of this, probably a state. Now, at that point, you have a decision. If the insurance is provided to the individual on the basis of underwriting, where the insurer, a seller-driven market, where the insurer can refuse to offer coverage, then what you do is you send that sick individual over to a high-risk pool. The excess cost is then passed back on to all those people you did give coverage.
I wrote the state high-risk pool legislation encouraging.
So all I'm saying is a risk transfer pool is simply the same mechanism, but it's for a market where it's guaranteed issue and you can't send the individual off. You take the individual, you send the claim off.
Let me change topics. Ms. Capps just talked about the fact that she loved the California mandates. She likes certain things that are mandated under California law for coverage. You mentioned earlier one of your concerns about a so-called public plan, and I think you're right. It is the current system in vogue, or the idea in vogue, would be, well, what does it cover, what doesn't it cover it? I think you also touched upon a point that I think I touched upon in my questioning earlier, and that is, if the government offers a public plan and the government also sets the rules for that plan and for all the other plans, isn't the government both a player in the game and the referee of the game? And I'd like to see if you do agree with that point and if you'd expand upon it.
Well, very simply, the last point, if the government will always be the rule setter. So in a state, any state right now, they could set up a public plan in competition. I mean, Massachusetts could do it with the connector if they wanted to, okay? You will always have that question of, do they play by exactly the same rules? Because what we know is that when you have different rules, then you will have market segmentation. We've seen this in Maryland. We've seen this, I mean, I've just been dealing with Washington State, where they allowed association plans, one set of rules for the small group market and commercial insurers, another set of rules, and it's created all sorts of problems. So So the first rule, whether it's a public or private plan or two groups of private plans, is everybody playing on the same rules. So that's one level of questions that you would confront regardless at any state. Now, if you're at the federal level, you have all those questions, but now you have an additional set of questions. And the additional set of questions is, well, the 50 states have different standards. As Representative Capps pointed out, whose standards are we going to apply nationally? Okay, so you have all the same set of questions you have to deal with, plus you have another set.
We're going to have to end it. Dr. Kinsdale, you said there are 100,000 people who have not joined or not paid in. They're simply unenrolled. What in the first year, right? That was going back to 07. What's the system do for or about them? How do they get care?
Quickly, because we have to vote.
Okay. So if they are, well, if they're low income, they wouldn't be subject to that penalty. So they would basically be self-pay. They're part of the 2.5% that we haven't insured.
All right.
Okay.
We're going to run out of time if we want to vote. Thank you all. Again, this has been very helpful in our efforts to try to put together legislation. And you may get some additional questions from members that you can respond to in writing. The clerk will notify you of that. But without objection, this meeting of the subcommittee is adjourned. Thank you.
They have to go vote.